हाय हाय पराग। बधाई हो आईसीओजी के लिए।
Yeah, thanks. Hi, Rishma.
Hey, good evening. Uh,
हाय हाय।
Good
Good
evening.
evening.
We are live. This is Dr. Manish. I am the head medical and regulatory affairs at Universal NutriScience, and I would like to welcome all for this seventh webinar on the ISAR Fertility Catalyst webinar. This is a webinar which, with the blessings of Dr. Amit Patki sir and Asha Bakshi ma'am, and with the help of Anu Agarwal and Fassi Lewis, sir, we have been organizing every month for the past 7 months. And this is happening virtually every Tuesday of either the first or the second week of the month. Today, we are blessed to have all the stars, including Rishma Pai ma'am, Dr. Parag Biniwala sir, also as a chief guest and guest of honors. And today, the topic is a mixed bag. And just to give a overview, UNS is the partner for this, along with ISAR for these monthly webinars. And as you all would know, that we are the makers of the pioneer brands like CoQ300 and other brands in this field. With this, I'll just give a brief intro of Dr. Anu Agarwal, ma'am. She hails from, she is attached as a director of Vansh Fertility and Test Tube Baby Center, and she is based out of Varanasi. And she is the committee member as well as has several publications to her credit. With this, I'll pass it on to ma'am for further proceeding. Ma'am, over to you.
Thank you. Thank you, Dr. Manish. So, good evening to all esteemed doctors. It is a real pleasure to welcome you all on behalf of Central Team ISAR in this ISAR Fertility Catalyst series. I'm sure today's webinar will act as a catalyst for all of us in clearing all our doubts about the use of letrozole in gynecology and use of gonadotropins in IUI. So Dr. Amit Patki, he will be joining later as he's stuck in some emergency. So I'm honored to invite Secretary ISAR, a vibrant Dr. Asha Bakshi Madam, for her blessings.
A very good evening to all, and thank you, Anu and Dr. Fassi Lewis, for doing these webinars. These webinars are really getting popular, and I wish you do more and more. And your selection of topics is very good. It really helps every common clinician, not only the infertility specialist, but other gynecologists also. And it's indeed a great pleasure to welcome Dr. Rishma Pai, who is a one of my favorites, and not just favorite. The reason is that she is very knowledgeable. She really is a very good administrator and very well disciplined herself. And she disciplines our Dr. Rishikesh Pai also. So that is a specialty. And I've seen that because I have been Dr. Rishikesh Pai's vice president, and I know that how much he praises her, that, oh, she will say that, she will. So that's what I like about her, that she has a good control. And then Dr. Parag Biniwale, who is a good friend, and at the same time, he is chairperson ICOG, and during his tenure, we will see lots of good activities in ICOG. So welcome both of you. And today the topics selected are really good. Letrozole, which we all use, and there are so many points and how we can use it in our day-to-day practice and give economic treatment to the patients. So that Dr. Sachin Dalal is going to talk about. And Dr. Kedar Ganla, he is really good. He has a good sense of humor also, and at the same time, he gives good messages across. So he will tell to us about gonadotropins. And again, Kaberi, doing the panel discussion, she's a very straightforward person, gives exact messages to clinicians, what is to be done, there is no confusion. So very good selection, and I'm sure that this overall webinar is going to be very useful. And I wish to see you all and with your friends at Lucknow in ISAR annual conference. So thank you very much, and all the best.
Thank you. Thank you so much, madam. I'll request Dr. Fassi to invite our beautiful chief guest and dynamic guest of honor. Dr. Fassi, over to you.
Okay. Good evening to all of you. Good evening, all ISAR members and doctors. It is my proud privilege to be co-convener along with Dr. Anu Agarwal for this wonderful initiative by ISAR President Dr. Amit Patki and Secretary Dr. Asha Bakshi. And today we are more delighted to have a very respectful and knowledgeable chief guest for our this webinar. It is none other than Dr. Reshma Dilan Pai. Just to introduce her, actually, she doesn't need any introduction. She is a consultant gynecologist at Leelavati Jaslok and Hinduja Hospitals, Mumbai, treasurer of IFFS, International Federation of Fertility Societies, and FIGO member of Menstrual Disorders Committee, and former president of FOXI, ISAR, IAGE, and Mumbai Obstetrics and Gynecology Society, and honorary fellowship for COGO by the Royal College of Obstetrics and Gynecology, and FIGO Women's Award at Paris for outstanding contribution to women's health in 2023, and awarded the Lifetime Achievement Award by the TAPISAR and ISSFRF in 2021 and 22. And also BN Purandare Award, the most prestigious award of the Mumbai Gynecology Society, and Health Mentor Award from the Health Minister of Maharashtra, and Power Woman Award presented by the Governor of Maharashtra, and Vidya Bhushan Award by the ICOG 2021. These are only the icing part of the cake. The big cake is a lot of honors are there. I'm just told only the latest one. Over to you, madam, for your blessings.
Thank you. Thank you. Good evening. Good evening to all of you. Thank you for making me a part of this very, very prestigious webinar series of ISAR. I think under the leadership of Amit Patki, all of us have seen what amazing work he's done. And Asha is one of the most hardworking persons, whichever position she's in, whether she's vice president of FOXI or whether she's at the ISAR leadership. Extremely hardworking and wonderful person, and equally fun on the side. So amazing team, and we are so looking forward to Lucknow in the next couple of days. It's going to be an amazing event as well. So I really think that any webinar which has come to series 7 is truly fantastic. I mean, something which is continuing in today's competitive world, to be able to have episode 7 or series 7, this set of Fertility Catalyst webinars is really very, very successful and very popular, and really well backed up by these two young people, Anu and Fesi. So I think you all are doing a great job. Congratulations for that. My privilege today to be with the only one person in FOXI who calls me Mrs. Pai, and that is Parag. He's the only one who addresses me as Mrs. Pai. So, dear friend, and of course, a great leader of the ICOG. So wonderful to be here with all of you. Anu, thank you. You've always made such an effort. She's been very, very, sort of persistent, calling me, making sure I attend. And we worked together in the past. We've written a couple of articles together and done some publications together. So extremely academically oriented young lady. And Fesi, of course, we go back a long way. We've done lots and lots of work together. So I think with these kind of hardworking people behind this webinar series, it's bound to be successful. And everybody's already mentioned some of the topics we are discussing today. But to me, one topic, and that is gonadotropins in IUI, I think it's extremely important because most people are very scared. The basic gynecologists who have gone on to IUI are a little scared to use gonadotropins. They're okay with oral ovulogins, but gonadotropins is hard. So I feel, confidence building, hand holding, while they progress from using just, for example, letrozole, which is a wonderful drug, but going on from letrozole to gonadotropins, I think all of these things will really help them, give them the confidence that, yes, you can use some degree of gonadotropins in IUI. And then, of course, when you progress to IVF, there's a lot more to be, learned and done. So I really don't want to take much time because we have a wonderful event lined up. I just really want to say that to improve really is to change. That's very, very important. We have to change if we want to improve. So to improve is to change, and to be perfect is to change often. And so every now and then we have to keep changing, we have to change often, and that's how gradually we will move towards improving ourselves and work towards perfection. So all the best to all of you who are trying to achieve perfection in everything that you do. You all are getting there. Nobody's perfect, but you all are coming close. So all the best to you. Thank you so much. And Liz, looking forward to many, many more of this series. I'll come back again as chief guest for the 17th. Okay, so when you have your 17th webinar, call me. All the best.
Thank you. Thank you, madam, for your blessings.
Thank you, madam. Thank you, madam. I think over to Anu to introduce our ICOG chairperson.
Yeah. It's an honor to introduce Dr. Parag. We all know him very well. Dr. Parag is senior consultant. He's PG teacher and unit head at Kamla Nehru Hospital and is chairman of Indian College of Obs and Gynecology Society and president of Menopause Society Pune, Pune Obs and Gynae Society, and president ISAR Pune chapter. And he's a Foxy national website editor and peer reviewer of Journal of Obs and Gynae of India and Journal of Midlife Health. Sir is chairman, Young Talent Promotion Committee, Foxy, and so many publications to his credit. And Sir has delivered various orations and has guest lectures in over 160 Foxy societies, recipient of Best Paper Prize in AICOG and AMOGS. Welcome, Parag, sir.
Thank you, Anu, for those kind words. Good evening. I bring greetings from ICOG, and it's indeed a pleasure to be part of this webinar. So thank you for the honor. It is a pleasure because the president of ISAR is Dr. Amit Patki, who is a very dear friend for last 25 years. I also get an opportunity to share the virtual dais with Dr. Rishma Pai, who's the past president of ISAR and Foxy and a very dear friend. And Asha Bakshi, who is the Secretary General, she was my governing council member when I took over as the secretary, and Fesi is my current governing council member. I'm not a hardcore fertility person, but being chairman of the ICOG, I am responsible for continuing education in the field of reproductive medicine. So without taking much time, I will just appeal to all the ISAR members and ISAR leadership to join hands with ICOG, because we have 6 months and 1 year certificate courses which are conducted at various centers. Asha's is one of the centers for young gynecologists who wish to enter the field of fertility management. So we would certainly join hands, and we would invite you to be a faculty in our lecture series, because we want all of them to learn the right things from the right people. So once again, thank you very much for this opportunity, and my best wishes for the program. I would have loved to listen to this because, like Rishma said, I'm a general gynecologist and I'm not a fertility person. But soon I'll have to leave because we have a launch of Foxy initiative called Do Tike Zindagi Ke, which is scheduled in half an hour's time. So thank you very much.
Thank you, Dr. Parag, for giving your pearls of wisdom and gracing this webinar. Thanks once again. And I hope that, as you told, this the topic will be useful for all the gynecologists, not only for the ISAR members. Over to you, Anu.
Thank you, Parag, sir. So we are going to start our first session, all about letrozole. And we all are very excited to hear you, Dr. Sachin. And today's speaker, Dr. Sachin. Dr. Sachin, I think everybody knows you, but a short introduction.
That's okay. This is slide everybody has seen. We start off. I don't want to keep the other speakers waiting.
Formality.
Let me call our chairpersons for today's session, for this session. Our first chairperson is Dr. Radha. Madam is professor and head of reproductive medicine and surgery. She has done PhD in the field of reproductive medicine and surgery. She is secretary, ISAR. Welcome, Radha, madam. Our next chairperson, Dr. Mehul Damani. Sir is director of Planet Women IVF Center and Women's Hospital. and ex-honorary assistant professor, VS Hospital, President-elect Gujarat ISAR. Welcome, sir. Dr. Sarfaraz Nawaz Qazi. He is a consultant gynecologist, endoscopic, and infertility specialist since last 20 years. And he has experience in running high-risk pregnancy unit since 20 years at Himmatnagar. And he has done fellowship in reproductive medicine. Welcome, Dr. Qazi. Over to you, Dr. Sachin.
You are muted, Sachin.
Yeah, thank you so much. I'd like to share my screen. Yes. Okay. Are the slides seen on the screen?
Yes, make it a slideshow.
Yeah, I'm making a slideshow. Okay, and is it moving?
Yes.
Perfect. Okay, at the outset, thank you, Dr. Anu Agarwal and Sasi sir, for the kind opportunity. Thank you to ISAR, ICOG for having me here to speak on letrozole in gynecology. This talk I've given at multiple places, multiple fora, and a lot of people across the country have got benefited by it. So, basics, if the woman is ovulating regularly, she is having good recruitment, rupture, good corpus luteum, we are absolutely happy that she is going to conceive on her own. However, the problem comes when it is a PCO, where there is supraphysiologic synthesis of estrogen. Estrogen gives a strong negative feedback signals to the hypothalamus and the pituitary. This causes a low GnRH production with positive feedback on LH. So we have a problem that FSH is low, LH is high. Now, as we all know, FSH is the one that is. Can everybody be muted at the back, please? Yeah. As we all know, FSH stands for follicular stimulating hormone. If the FSH is going to be low, the recruitment is not going to occur. And that is the problem why no ovulation takes place. Now, coming into the picture, how do we tackle this? We all know of the aromatase enzyme, which converts androsterone and testosterone to estrogen. This goes and acts on the pituitary. It helps to stimulate the GnRH, FSH and LH is stimulated, and the follicular recruitment occurs. When we give letrozole, this inhibits the aromatase enzyme. The pituitary realizes that estrogen is lesser. This will push more GnRH, which will increase the secretion of FSH and follicular recruitment will occur, especially in anovulatory women. So, looking at the clinical applications of letrozole, we all have been using it in ovulation induction, be it for plant relations or timed intercourse, IUI, IVF, endometrial preparation for FET, endometriosis and adenomyosis, ectopic pregnancy, arteriovenous valve formation, or the new name is enhanced myometrial vascularity. And we all know the role in CA endometrium, CA breast, and nowadays CA ovary as well. So we can definitely say that this one simple drug is a super drug. This is a standard letrozole protocol which all have been using. We start from day 3, one daily for 5 days, scan the lady. If the follicular recruitment has occurred, stop it. Let the follicle grow. Once it goes to 18 to 20 millimeters, lining is good. Give the HCG trigger, do an IUI or timed intercourse as the case may be. A few points here. Always start on day 3 instead of day 2 in a 28-day cycle, because we have seen that if in a regularly ovulating lady or a woman who's having a regular menstrual cycle of 28 to 30 days, when we start on day 2 instead of day 3, the follicular phase gets shortened and you have a condition wherein the follicle is 18 to 20 millimeters, but it's on day 9th or day 10th, and the endometrium is still lagging behind. And then you really don't know what is to be done. So the simple thing is, instead of starting on day 2, always start on day 3. Looking at the extended letrozole protocol, this I've shared across various groups since a long time, especially post-COVID. This is to be used for our standard clomiphene resistant and normal letrozole resistant PCO women. What is the normal letrozole resistant women? Women who will ovulate with the standard dose of 5 tablets of letrozole. In these women, I recommend giving 2 months of pre-treatment with metformin, minoxidil, decarbamazole, or both. I prefer a combination of metformin plus MI plus DCI. A lot of brands are now available because that gives a better control in the management of PCOS and the internal hormonal milieu is better. Mentioned start the first cycle with 2.5 milligram OD, give till the lead follicle is 16 millimeters. Why 16 millimeters? A lot of times it does occur that we've stopped it at 12 or 13 millimeters, and after that, the follicle just goes into a arrest. And then we are not sure whether we want to add gonadotropins, cancel the cycle. So we have seen that if we continued giving it till 16 millimeters, this is the time where the FSH threshold has been crossed, and after that, the follicular arrest will not occur. Increase the dose to 5 milligram, 7.5 milligram, or 10 milligram if no response is obtained with 2.5 milligram, or start with 5 milligrams straight away if the weight of the woman is more than 60 kilograms. Because we have seen that with a woman with more than 60 kilograms, the letrozole 2.5 milligram does not cause a follicular recruitment. As mentioned, start from day 3 instead of day 2 in all patients. If you are not doing IVF or you do not have access to an IVF center, it would be prudent to cancel the cycle if more than 4 follicles of 14 to 15 millimeters are forming or grown to prevent OHSS. Always trigger with a HCG 10,000 or RHCG or a dual trigger where we would give HCG 10,000 plus Lupride 1 ml. Since the past 2 years, I have started giving HCG 10,000 plus Lupride 1 ml for all my patients, be it timed intercourse, be it IUI, for the simple reason, a lot of times you've seen that even after giving HCG 10,000, follicular rupture does not occur and the entire cycle goes wasted. Since the time we've started using the combination of two, the chances of the follicular rupture not happening has been minimized to less than 1%, thereby salvaging the cycle, and it hardly costs anything. I like to give dydrogesterone 10 milligram twice a day, or a micronized vaginal progesterone 200 milligram BD, or a NMP SR 200 molecule 2 times a day for 15 days for luteal phase support. Why I would like to add progesterone in luteal phase support? Because as we all know, it supports the endometrial growth for successful implantation. It has a utero-calming effect. It suppresses the uterine contractions. And most importantly, it modulates the immune response to prevent the rejection of the embryo. So it is prudent to use progesterone for luteal phase support. And we really don't know which patient might be having a luteal phase defect. So a simple progesterone twice a day for 15 days in the luteal phase after the rupture is documented is a good idea to go ahead with. Now, amongst the first person to mention about the extended letrozole therapy was Badavi in the year 2009 when he had published a paper in Fertility Sterility. So in this, what they did is 2 groups of patients, one where they gave 2.5 milligram of letrozole from day 1 to day 10. In other group, they gave 5 milligrams of letrozole from day 1 for 5 days. That means one group got 5 milligrams for 5 days, that is total 25 milligrams cumulative dose. And the long letrozole group got 2.5 milligram daily for 10 days, that is the long letrozole group. Look at the difference. Though the total dose intake is the same, 25 milligrams, in the short letrozole group, you have lesser number of patients who are ovulating compared to the long letrozole group. Number of follicles is significantly more in the long letrozole group with a similar endometrial thickness. And look at the pregnancy rates. The pregnancy rates are almost 1.5 times more in the long letrozole group compared to the short letrozole group with almost similar miscarriages. Thereby, if we can give a prolonged treatment of letrozole in this women, we might have a better pregnancy rate compared to the standard short letrozole group. So this is probably you can just do a in-house study, of your own patients and see what is working for you. the short protocol or the long letrozole group protocol. Now, this was a nice study published in a Russian journal. It was called as the STAN-STEP protocol. They had two groups. One was the standard letrozole 2.5 milligrams given from day 3 to day 7, scanned on day 14. If follicles were not recruited, on day 21, they did an ultrasound, did serum progesterone. If serum progesterone was not more than 1, that means no ovulation had occurred. They gave progesterone for 10 days, waited for the periods, and from the next cycle, they gave 5 milligrams of letrozole. Now, this was the standard protocol that we all followed. They did something novel. What they did, they started with letrozole 2.5 milligram daily from day 3 for 5 days. Day 14, they scanned her. If the follicles had recruited, fine, continue with the standard protocol. If not, they made it letrozole 5 milligrams daily for 5 days from day 15. Again, they scanned on 26th day to check whether follicular growth had occurred. If it had not occurred, they increased the dose to 7.5 milligrams a day. And then they did the standard follicular studies. Now, looking at the results, in the stair-step protocol, they found that the ovulation rate was much better than the standard protocol. Pregnancy rates, again, were almost 1.5 times more. Look at the mean time to ovulation. In the long letrozole protocol, it was almost half the standard letrozole protocol, with a better endometrial thickness in the long letrozole protocol, in the stair-step protocol compared to the standard protocol. So, take home points, you've given 5 days of letrozole, you see there is nothing, increase it to 5 milligrams. If there is nothing, increase to 7.5 milligrams. So you have a condition where instead of cancelling the cycle, you can salvage the cycle and continue with the cycle. Step-up protocol, this study was published in 2012. First cycle, they gave 2.5 milligrams daily from day 3 to day 7. Second cycle, they 5 milligrams from day 3 to day 7. Third cycle, they increased it to 7.5 milligram daily, again from day 3 to day 7. And what they found, in first cycle, with 2.5 milligrams, 22% had follicular recruitment with 16% pregnancy rate. With 5 milligram, it became almost double of that, and 7.5 milligrams, it was double of that. Take home point, don't start with 7.5 milligram in all patients, because what I have observed is when we start with a higher dose of letrozole, the estrogen gets downregulated too much and the endometrium does not grow. So that is reserved for those patients who don't respond to the standard 2.5 or 5 milligram. Or if you have a patient who is extremely obese, who will not grow with 5 milligram, these are the patients who are not wanting gonadotropin and letrozole 7.5 milligram or 10 milligram. If she can afford in gonadotropin, Kedar is going to tell about it, the short protocol with HMG or extended protocol with step-up REC-FSH can work in such patients, but then the cost of treatment is high in such cases. Now, looking at letrozole for stimulation for ART. Till now, we spoke about for timed intercourse and for IUI. Now we will talk about for ART. They found that combination of corphoretropin alpha, which is not available in our country, it is a single dose injection of REC-FSH. The duration is for 7 days. With 5 days of letrozole was associated with higher number of developing follicles, total oocytes, and obtained embryos. Similarly, another study showed that poor responders may benefit from co-treatment with letrozole during ovarian stimulation for IVF, whereas letrozole for normal or high responders requires further investigation. Clinical points, you are doing IVF, you want to reduce the cost of treatment, try adding letrozole and see whether you are getting a better number of oocytes for the same dose of gonadotropin or by reducing the gonadotropin compared to not adding letrozole. And if it works for you, you can continue taking that as a part of your regular ovarian stimulation protocol. Now, this is something which I've been talking about since a long time. This is the first time I came about natural cycle FET was in 2019 Ashray, where the entire European Union has completely shifted from our hormonal FET to natural cycle FET or letrozole FET for the simple advantage of getting a corpus luteum. This is for ovulatory women or PCO women. Very simple protocol. Do a day 2, day 3 scan. Start letrozole from 2.5 milligram or 5 milligram daily. Again, you have to wait, continue giving it till the follicle crosses 16 millimeters. Once endometrial thickness is 8 millimeters, that is my cutoff. I like ET more than 8 millimeters. Follicle can be 16, 18, 20, does not matter. Trigger with HCG 10,000 or RHCG at night. I like to give HCG at night 10 o'clock. After 36 hours, that is day after tomorrow morning at 10 a.m., after the trigger, without confirming ovulation, straight start progesterone. What progesterone I would like to give? I like to give diprogesterone 10 milligram TDS and natural micronized progesterone 400 milligram capsule twice a day. If you are using progesterone gel, you can use OD or BD as per your clinical protocol. Give for 3 days for day 3 transfers and do FET on the 4th day. Give for 5 days for day 5 blastocyst transfers and do FET on the 6th day. So simplifying, on Monday, you saw the scan, endometrium is 8 millimeters, follicle is 17, 18, 19 millimeters. Monday night, give trigger with HCG 10,000. Wednesday morning, 10 o'clock, patient will start progesterone. 5 days she will take progesterone, Wednesday, Thursday, Friday, Saturday, Sunday. And Monday morning, 10 o'clock, you can do the FET. The advantage here is one, corpus luteum will reduce the incidence of IUGR, PIH, and other complications of pregnancy that we are seeing with hormonal FET. And secondly, the cost of treatment goes down significantly. And most importantly, post-COVID, where we are seeing a lot of women getting venous thromboembolism, since we are not giving estrogen, there is no scope of these girls getting venous thromboembolism. And most importantly, there is absolutely no need to give estrogen separately, either before or after FET, when you are doing a letrozole for a natural cycle or a modified natural cycle FET. Now, looking at the review of literature for FET, these are 5 papers which I have just taken the salient points. Letrozole endometrial preparation improved the live birth rates compared with the natural cycle without adverse effects on perinatal outcomes and congenital anomalies. The advantage that we get with letrozole, as we know that when the follicle is growing, we can time the trigger and then start the progesterone. While in natural cycle, you have to call the patients frequently and she needs to do multiple times blood tests of E2, progesterone and LH to determine when the LH surges occurred. Stimulated cycles with letrozole present a relatively large advantage compared to HRT cycle and natural cycle with higher live birth rate. So this paper showed that letrozole cycle gave a higher live birth rate compared to even a natural cycle. Letrozole clinical outcomes were improved compared with programmed FET cycles. Ovarian stimulation protocol as an endometrial preparation regimen prior to FET might be superior HRT protocol with a significantly higher rate of live birth, lower risk of miscarriage, preterm birth, and preeclampsia because of corpus luteum. And another last study showed that stimulated protocol is better than HRT regimen in endometrial preparation for women with PCOS. Only 2 places where you cannot use letrozole is one for women who have undergone menopause. There is no follicle which is there to be recruited. And second, absolutely severe PCO. Obese women, these are the women who will not respond to letrozole, and these are the patients who you will have to add HRT as the standard FET protocol. Second indication is endometriosis. So first we finished the fertility part. This is the second indication, endometriosis and adenomyosis. As we all know, a lot of our patients come with severe debilitating pain during menses, severe dysmenorrhea. And these are the open surgeries, the triple hood surgery, which have been done since time immemorial for the treatment of bulky adenomyosis. As we all know, endometriosis or adenomyosis is an estrogen dependent chronic inflammatory disease affecting 5 to 10% of reproductive age group women. Molecular studies have revealed the presence of aromatase P450, the key enzyme in biosynthesis of ovarian estradiol inside the endometriotic tissue. Hence, the premise of using letrozole because it is an aromatase P450 enzyme inhibitor in treating endometriosis. So looking at review of literature, one literature found that letrozole is capable to treat deep infiltrating endometriosis involving the rectum and the urinary tract. Letrozole combined with dydrogesterone effectively decreases the levels of VEGF, CA125, estrogen, progesterone, IL-6, and TNF-alpha. So if you have a woman who is having endometriosis and is desiring fertility, as we all know, dydrogesterone does not stop or does not suppress ovulation. Letrozole will cause ovulation, endometriosis will be suppressed. Letrozole will keep estrogen levels low, so the pain and the symptoms will be lesser, and you might just find that the patients get pregnant on their own. Another study found letrozole was as efficient as GnRH analogs to relieve dysmenorrhea and dyspareunia, but not for chronic pelvic pain. Reduction of the uterine volume was seen with aromatase inhibitors, GnRH agonists, and LNGiod, that is Mirena. Now, where we can use the letrozole for first indication? You have a woman who is unmarried and she is not wanting to undergo the surgery for deep infiltrating endometriosis, though, as we all know, that is the first line of treatment for DIE. So, these are the patients where you can give letrozole. Second, patient has already undergone surgery, but the clearance was not complete. These are the patients where you can give letrozole. And thirdly, you had a patient who had undergone surgery, and after 1 or 2 years, there has been a recurrence. These are the patients where you can try letrozole. Looking for patients with endometriosis for ART, one study found that gonadotropin dose and estrogen levels on the trigger day were significantly lower with the letrozole group. No significant differences were detected regarding biochemical or clinical pregnancy. So in endometriosis, since we like low estrogen levels, letrozole will ensure that with no difference in biochemical or clinical pregnancy rates. Another study found clinical pregnancy rates and live birth rates improved after pre-treatment with letrozole added to the GnRH agonist treatment versus GnRH agonist alone. So we have given GnRH agonist Lupride depot post-surgery, wait for 3 months, and then do IUI or IVF as per the case, along with GnRH agonist and letrozole, and you will find that the clinical and pregnancy rates and the live birth rates are much better. And lastly, one study found that combination of Luprolide depot monthly for 60 days, that is for 2 months, combined with daily letrozole 2.5 milligram, has better clinical outcomes at IVF in women with endometriosis than a depot of Luprolide alone. Ectopic pregnancy. Now, this is very interesting. In the lockdown, I had a patient with early ectopic unruptured beta HCG 2500. We could see it on ultrasound. There was no yolk sac, confirmed beta HCG. And she was not willing for admission because that was the time that no one was willing for admission. I'm talking about, 2020 and January 2021. I just thought, let me check out medical management options for ectopic pregnancy other than methotrexate, because I had bad experience with methotrexate in the past. And this patient was herself a lawyer. She was not willing for methotrexate injection. So I came across this excellent paper by Mitavali et al., where they divided women into two groups. First group got the standard methotrexate, 50 milligrams per square millimeter body surface area. And second group, they gave letrozole 5 milligrams. They have 2.5 milligram tablets, unlike us. So they gave 2.5 two tablets, that is 5 milligrams, daily for 10 days. They noted complete resolution of ectopic pregnancy in equal number of patients. Methotrexate was associated with statistically significant higher liver enzymes and lower blood platelet counts. Most importantly, the decline of beta HCG was faster with letrozole than methotrexate. And for us fertility consultants, I mean, you have a patient who's, conceived after IUI or IVF, they noted that 3 months after treatment with letrozole, AMH levels were lower in the methotrexate group when compared to the letrozole group or for the surgery group. So another group in 2022, they took this further, where they divided 60 women with undisturbed ectopic pregnancy, beta HCG less than 3000, unruptured, no cardiac activity, into 3 equal groups. Group 1 got the standard laparoscopic salpingectomy. Group 2 received letrozole 5 milligram daily for 10 days. And group 3 got letrozole 10 milligram daily for 10 days. They found that letrozole 10 milligram daily for 10 days results in a higher successful rate without severe side effects. So in my clinical practice now, if it's an unruptured ectopic pregnancy with no fluid or blood in the POD, patient hemodynamically stable, beta HCG less than 3000, no cardiac activity, patient willing for regular follow-up, letrozole 10 milligram daily for 10 days is my first protocol for ectopic pregnancies unruptured. And I have treated scar ectopic pregnancy, tubal ectopic pregnancy, and angular ectopic pregnancy with letrozole 10 milligram daily for 10 days with excellent results. So maybe you can try this in your clinical patients and update on the WhatsApp groups. How was your experience with that? Now, this is another very interesting thing that I came across. In my 20 years of practice, I never had seen a single patient with arteriovenous malformation, or the new name is the enhanced myometrial vascularity. In 1 month, I got 3 patients of the same, and I told them about the various options available. I will be telling about that. And I wanted to see whether we can have something to medically manage the arteriovenous malformation. So doing review of research literature, got this fantastic paper from the Canadian journal published in 2019. This is the only paper, mind you, which has used letrozole with tranexamic acid and GnRH agonist for treatment of arteriovenous malformation. They found all 20 women resolved completely in 1 to 3 months of treatment, out of which 16 women who attempted pregnancy became pregnant and conceived spontaneously with live births. And they found that 2 women are using contraception. One is 40-year-old and not using any contraception. And 1 woman had hysteroscopic endometrial ablation followed by vaginal hysterectomy for AUB 1 and 2 years later. So this is my own personal experience. As I mentioned, 3 patients with confirmed AVM or enhanced myometrial vascularity, that's a new name, on Doppler ultrasound, confirmed with a radiologist. All complained of bleeding PV post MTP. 2 were given MTP kits. 1 was given by us, 1 was by another doctor, and 1 was DNC done by us. All 3 ladies were given 3 options. 1, the standard bilateral laparoscopic interlinear artery ligation. 2, uterine artery embolization. And 3, the medical management. All opted for medical management. We took their consent that this is an experimental therapy. It might work, it might not work. So what we did as per the paper of Canadian journal, gave Lupron depot 3.75 milligram stat and letrozole 5 milligram daily for 15 days. Combination of tranexamic and ethamsilate was given for symptomatic pain relief, which was usually given for 5 to 7 days. And all patients were followed up on weekly basis. They were called up by my staff on daily basis, how they are feeling, they are having any bleeding, any pain in abdomen, any giddiness, or any other side effects. And all women had complete resolution of AVM in 2 to 3 months' time. This is a video of one of my first patients. As you can see, this is the vascularity, which is going right up to the outer myometrium. This is pathognomonic of the AVM or the enhanced myometrial vascularity. And after giving the treatment, this is the picture where you can see significant reduction in the vascularity. This is the same patient after 1.5 months and complete stoppage of symptoms of bleeding for vaginum or pain in this patient. And lastly, this is my last slide, letrozole in cancers. As we all know, everolimus plus letrozole results in a high clinical benefit rate and confirmed objective response rate in patients with recurrent endometrial carcinoma. Another study showed they've used management of they've used letrozole in the management of advanced ovarian cancer. They found that letrozole, which has a favorable toxicity profile, seems to assure a prolonged recurrence-free interval, particularly when used as a maintenance treatment in low-grade serous ovarian cancers in recurrent cases, as it had led to prolonged disease control. And last but not the least, we all know of the use of letrozole since long in treatment of estrogen receptor positive patients with CA breast. And thank you so much for the opportunity to present my data with letrozole.
Thank you, Sachin. Over to chairpersons.
Yes, I'm Dr. Radha here.
Hello, madam.
Yeah, yes, sir. It was a very wonderful presentation. So a lot of things you have discussed in this. And your focus on the extended letrozole therapy and all that was really very good for a practitioner to follow that, especially in a situation where we are not able to use the gonadotropins. So,
Absolutely.
yes, sir. And the other important uses, yes, you are talking about the ectopic pregnancy and adenomyosis. We are using in our tertiary care center. So we are getting very good response, especially when you're planning for an FET cycle. Yeah, that is one thing. And the other thing which was really something new for me was in patients with AV malformation. So I think I should try. And my one of the other thing which I wanted to know was I have a situation where the patient has endometrial hyperplasia with atypia. And does it have a role in that cases? Because you are talking about the endometrial carcinomas.
No, so if you have a endometrial hyperplasia with atypia, the best thing to do in such a patient is put a intrauterine LNG IUS. If she's not willing for that, give her monthly Depo-Provera, 150 milligrams once a month for 3 months, and she will be fine. And observe her on a monthly basis for the shrinkage of the endometrial thickness. But letrozole
Yes,
has
sir.
no role
Because
in that.
yeah, because she has associated adenomyosis. So I was just thinking whether it has a
So,
role.
so, so, so in,
Yeah.
in this case, madam, what you can probably do is put in a LNG IUS and give her
Yeah.
letrozole 2.5 milligram daily and see how the response is. But
Okay.
my treatment choice for patients with adenomyosis not wanting childbearing is putting a LNG IUS, and I start them on orviloxifene. It is
Yeah.
available from two companies. One is Sevista, another is Novex. 60 milligram twice a week for 2 months. After that,
Mm,
reduce to 30 milligrams twice a week for 2 months. After that, reduce it to 30 milligrams once a week for another 2 months. I have a lot of patients who are taking it since almost last 10 to 12 years with just once a week. Some patients, one of my doctor patients is taking it once a month and she's absolutely fine, pain free, no bleeding, nothing. So I tell educated patients, you decide what the dose is suiting for you. Once in 10 days, once in 15 days. And as a doctor patient is saying, like, sir, I take only 30 milligrams once a month and it's fine. So, like, perfect. No
yeah.
hyperplasia, no ovarian cysts with that. And cheapest medicine that is available. And since
Yes,
it's
sir.
a non-steroidal estrogen receptor modulator, it can give it for a long period of time without worrying about any bone mineral density reduction or any ovarian cyst formation, etc., etc.
And I was just thinking, you said you will be giving a 10,000 IU of HCG for it.
For
So,
all patients,
is
all
there any
patients.
reason behind?
I'll tell you. So post-COVID, we noted, and I've changed multiple brands. HCG 5000, when we used to give standard for trigger, we had a lot of patients who just not rupture. I mean, a lot of people would then say after 36 hours and give another trigger. That does not work. Your LH surge has already occurred, but it was insufficient to cause a trigger fail, the rupture. So then we started giving HCG 10,000. Observe the same thing. Then I thought that let's
Mm,
start doing a dual trigger for all patients, be it timed intercourse, be it IUI, be it IVF. Of course, we are using a dual trigger, except if it's a long agonist protocol. And we found that our unruptured follicle rate has gone down to less than 1%. All patients rupture. Clinical pregnancy rates are better because we've come across a lot of papers where they've given agonist 1 milligram in the luteal phase for the support of the luteal phase. So where
yeah.
you're giving a HCG which is have a long half-life with a leupride, which is going to have a short half-life, you have leupride which is going to cause the FSH and LH surge, and HCG which is the pseudo for LH, the chances of fall. Acha, another thing what happens is since agonist gives a FSH surge, the follicular maturity is better compared to just
Yeah.
HCG which is just rupturing that. So your
Mm,
pregnancy rates are better with a dual trigger than a single trigger. And the cost is nothing.
yeah.
Like one pharma company, I'll not take names, everybody knows, has come out with a single usable ampoule of 0.5 ml, which has 1 milligram of lupride, and it works super.
Yeah, and one more thing is of late we are also using more and more of letrozole in patients with adenomyosis. Are you going with a fixed like a period of 3 months or 6 months, or you are taking the uterine volume into consideration before you
Uterine,
say yes, I'm going?
Uterine volume, it takes usually 3 to 6 months for reduction of almost 15 to 20%. But along with letrozole, I like to give a GnRH depot. So if it's a bad endometriosis, don't use Lupride, use Zoladex, which is 100 times more potent than Lupride. It is not very easily available nowadays, but Zoladex is called a Zoladex implant that works better. So Zoladex along with letrozole give her calcium add back, and you will find that the uterine volume shrinkage in adenomyosis is excellent.
Do you have any cutoff values for uterine volume, sir, before you decide, yes, I can go ahead? Nothing like that?
I mean, as we all know, the standard uterine size would be 8 to 10 millimeter at 8 to 10 centimeters by 6 centimeters by 4 to 5 centimeters. Now you have this bulky adenomyosis where uterus is 115 or 120 centimeters long. 15 to 20 centimeters long, 6 to 7 centimeters broad. So I would like the uterine volume to come down to as near as possible. So these are the patients where I would give them 3 doses of Zoladex, and we've seen drastic decrease in the uterine volume. If she is having a focal adenomyoma, I like to do a laparoscopic adenomyomectomy, give Zoladex post that, and we've found that because when there is a big adenomyoma, compression on the endometrial lining occurs, which will prevent the lining from increasing. So when you do the adenomyomectomy, the uterine volume becomes normalized. The endometrial thickness is better. So do the adenomyomectomy first, give 3 doses of Zoladex, that is the ultra-long protocol, and then do the FAT. But these are the patients where letrozole is not going to work for FAT preparation. You will need HRT. Again, at HRT now, I have stopped giving oral estrogen for all our patients. One brand which is available, I will not take names again. It can be used vaginally. When you put it in water, it dissolves in 5 seconds. And the dosage required is just 2 milligram twice a day. 2
twice daily.
2 milligram twice a day. So just 1 tablet in the morning, 1 tablet at night. So I tell the patients till the time she is menstruating, take it orally. Once the bleeding stops, put it vaginally. Till the time you add progesterone. And the lining is beautiful. I've never had to increase to even TDS. You can add arginine sachet, ecosprin as per the case. Stop giving GCSF and all those other paraphernalia in all these patients with FAT. And it works superb. And the chances of VT reduces significantly because you're just giving a 4 milligram dose.
What is that? Estradiol valerate or?
Sir, it is estradiol hemihydrate. I cannot put it on this. I will message it to you personally. You can put it vaginally. It works superb.
Yes, hemihydrate also has its value.
Hemihydrate, yes. And the advantage of hemihydrate, it has got a better liver toxicity profile. So if as a patient who's going to take it for 9 to 12 weeks of pregnancy, hemihydrate has a better liver toxicity profile compared to valerate.
Isn't it hemihydrate tablet is an entry coated tablet?
No. So one company.
Entry coated tablet, if you put it vaginally, then it will be very difficult.
So one company, Kedar, again, I will WhatsApp you personally. And I have seen it myself. Just put it in water. It dissolves in 5 to 10 seconds completely. So what happens, like in adenomyosis, you will be tempted to start with estrogen 2 milligram TDS, 6 milligram TDS, put a gel. You are giving almost 8 to 10 milligrams 3 times a day. Cut on that. Just give 2 milligram BD vaginally and see the results. So a lot of our colleagues have almost completely shifted from oral estrogen to this particular brand vaginally. I'm not the brand ambassador, sorry. I don't get anything from them. 2 milligrams twice a day, your dosage of estrogen reduces significantly. Your chances of VT will reduce significantly. And recently, at one of the meetings, I came to know of 3 patients pregnant post IVF with hormonal FAT dying due to venous thromboembolism in 1 month, and all the 3 IVF specialists were called for the maternal mortality meeting. So do we want that? Do we want that? We really don't want that. Thank you so much. I think I've
No,
used up my time and I'll
can,
not hold up together. Yes, Festival.
Chairperson Dr. Mehul Damani and Dr. Sarfraz, do you have any, please?
So, Dr. Fesi sir, there are questions in the chat box from Dr. Saroja Kapola ma'am and Yukti Bhardwaj ma'am and Neelams ma'am.
I thought the chairpersons will take
So,
that.
your chairpersons can take
Should
that.
should I just answer that? Let me just answer. So Dr. Saroja Coppola has asked, what is the role of letrozole? What is the role of letrozole in preventing OHSS? OHSS letrozole will reduce the estradiol levels, so thereby your OHSS chances are lesser. But if you given HCG trigger, OHSS can definitely occur. So if you feel that there are a lot of follicles and you given letrozole, stick to a regular agonist trigger. Now there is something which, since this has come up, Kedar sir, can I take 2 minutes?
No. I have been using letrozole and I have published papers on it. Even after using 1/3 of SCG and with a E2 of 5000 in my donors, giving letrozole for 8 days, I have been able to reduce the OHSS, severe OHSS in donors to less than 1%. So
Perfect.
it's a beautiful drug. Wonderful drug.
We are also using, we are also using that as well.
I will just suggest something which will reduce your chances of OHSS to 0. I have shared on the groups donors or hyper responders where you don't even want the donor to sniff HCG. I've started giving double agonist trigger. 2 injections of decapeptyl, 2 ml of lupride, 0.2 decapeptyl, 2 mg of lupride. That is total 4 doses. Lupride 2 she is taking together. Decapeptyl she takes 2 injections separately. 0 HSS. When you see these patients on day 3, day 4, ovaries have shrunken completely and excellent M2 rates, excellent embryo blastocyst formation. So I'm calling it as a double agonist trigger.
Give it together, all the 4 you give together?
All 4 to be given together at the same time. 2 decapeptyl 0.1, triptorelin 0.1, lupride 0.5 ka 2 doses, that is 2 mg. Okay. What is the rationale? We've come across patients with decapeptyl and HCG where we have had an empty follicle syndrome. We have had patients with HCG and lupride where we have empty follicle syndrome. I use this for the first time in a patient which had grown almost 60 to 70 follicles with just HMG 300. And I was sure she's will end up in HCG with a trigger failure, with the empty follicle syndrome, or with OHSS. So I thought to myself, let me try combining both together. And it is 60 follicles. We got almost 50 M2s and 22 blastocysts and 0 HSS. Patient pain free. मेरा staff उसको daily phone कर, my staff used to call up daily कि pain है, why are you bothering me? I'm absolutely fine, no problem.
Can I say something?
Yes, Kedar.
See, GnRH analog has got one property, to release the LH from the hypothalamo-pituitary axis.
Correct.
Now, most of your donors are on OC pills for a very, very long period of time, and their LH levels are suppressed.
Yes.
Now, who will get the chance of stimulating a donor, assembling the recipient, and then not to give SCG? Rather, giving same kind of drug in 2 different form of companies, I don't think so it is working. It will work. 1 minute. I am not finished.
I have had a lot of resistance in groups.
No, I understand.
This is what you are doing. Try and see.
I understand, but logically speaking, if I go to ESHRE conference and present this, they will just get up and walk out.
Forget ESHRE. I'm talking about India. You
No. Produce a trial, no then. Produce a trial.
No, see, as of now,
get a trial out of it and show it to us. Then it will become important.
So that is that's the reason.
No, sometimes Sachin, we are giving a message to such a big audience. if somebody uses 4 milligram of a 4 this thing of yours and they did not get oocytes, then where do they go?
No.
Where do they go?
What has happened is by giving 4 mg of the double agonist trigger, I had taken a poll in one of the fertility groups. Majority of the doctors have had excellent results with the double agonist trigger. So what I'm telling is, where you don't want to use HCG, try and see. Yeah, Ikika, you have a point to add.
No, I just wanted to ask one thing, Dr. Sachin. When mechanism of action, I mean for GnRH agonist, whether
It's
you
the
use
same.
leupride or it's the same, then
Yes.
I really want to know the logic, then why we are using a dose of this. The
Yes.
group, when you are saying that you have used 4 injections, I mean you have used Deca and leupride and you're getting the result. You might be getting it only with Deca also and leupride also. I mean, the worth of that giving 2 injections together of one type of a drug will come into action when you use it on the same kind of a patient.
So I
And
am
I
telling
really
you,
don't understand, when mechanisms of action is same,
it's
then why
absolutely
you
illogical. It is absolutely illogical. I'm myself telling it. It's illogical. But it has given me 22 blastocysts in a
that
place.
such as you could have got even with single
Even
Deca also.
yes,
How would you know?
yes,
How would you know? Is
and
it only because you are using
and
both of them? It
and
could be because of one of them also.
and Ekika, it's been said even if you use SCG 1500 IU,
Yes, yes.
it is good enough. The dose of SCG it will decide your hyperstimulation. If you give 10,000 SCG, which you are giving in IUI cycle, if somebody has 4-5 follicles
I'm
or
told to
more
cancel.
than that,
I'm told to cancel. If you are 4 to 5 cycles, there is a red line. If you don't have access to an IVF center, I have mentioned if more than 4 follicles of 14 to 15 millimeters are growing, cancel. It is there in bold in my presentation.
I think as we are running short of time,
I will
Actually, it's a very full of a debate kind.
I will give you one more suggestion.
Yes.
That what we do in a patient who has we give SCG to all my donors. Those who little overly respond, we give them mifepristone.
Mhm.
So on one side we am killing the estrogen, other side I am killing the
Progesterone.
VGF, third side I am killing the progesterone, and the fourth side I am giving Visalon to membrane stabilizing property. The patient gets a period itself on the 6th day, and the risk of OHSS just goes away.
Superb.
One mifepristone 200 milligram, and it is working very well.
Superb. Thanks for sharing it.
I am working on the paper on this.
Superb.
that is post pickup you give.
Post pickup next day.
And I wanted to add on, and I wanted to ask Dr. Kedar and Dr. Sachin also. I mean, I don't know how frequently you all use PPOS protocols for the donors. I mean, I have seen using these. As such, the results of that OHS is quite decreased when you are already using Clomita N and you give letrozole or maybe Capgolin. I have not seen many patients who have come with many donors which have come with the severe OHS or anything. Mild, yes, but not moderate or severe. So, I mean, when we have such good protocols and we do get results, I am not very much sure. I mean, all these new things are very nice. Sachin, you always come up with new ideas and new things. I mean, your work of letrozole in AVM and even for the cancers also. But even in your cancer slide, I also saw it is along with one of the anti-cancer agent.
Yes.
So how would
Yes.
I know it is not because of that agent and it is because of letrozole?
Read
So
that paper. I'll share the presentation. Read that paper. I don't treat cancer, so I just combine letrozole. Suripach, letrozole for AVM, you would be surprised, Ekika, across the country, 1,000 plus doctors have treated AVM with letrozole, and I'm getting so many feedback.
you are not giving letrozole alone. Even in that, you are giving it with GnRH agonist
GnRH
and
agonist.
letrozole.
Yeah,
Once
so what
again, how
letrozole?
can I say
No.
it is not because of GnRH agonist?
Again, it is
Ekika,
not my paper.
Ekika,
It is not my paper.
I think we will have the discussion.
Yes.
Yes,
Last
see,
Sachin always comes.
see,
Yes, sir. Please.
GnRH agonist is going to reduce the estrogen source from the hypothalamo-pituitary axis, and letrozole is going to reduce the peripheral conversion of estrogen.
Perfect.
Basically, what you need is hypoestrogenic phase.
Hypoestrogenic phase, yes.
That's it. That's the science behind it. we don't have to go in much.
You know, letrozole for scar ectopic, super
Yes,
results.
super results.
Letrozole for angular pregnancy, superb results.
Mechanism of action is going to be the same.
Same.
Ah,
So I have stopped operating. Means, of course, it is financially bad, but good for the patients.
No.
Okay. Dr. Anu,
No,
we will go
this
to
is
the next
not
stop.
something.
Kedar stop. Nanu, can you invite
Yeah,
Dr.
yeah.
Kedar?
So
Thank you so
wonderful
much.
discussion. And we can go on and on, but I think because of time constraint, so we will go for the next session. Gonadotropins and IUI. For this, I would like to invite our chairpersons for this talk are Dr. Beenu Handa. Yeah. She's fellow reproductive medicine and she's clinical director and unit head Cloud9 Hospital, ex-unit head Fortis Bloom IVF Center, and she's North Zone Coordinator, Foxy Endocrinology Committee. Welcome, Dr. Meenu. And next chairperson, Dr. Ekika. So many awards with her and publications, poster presentation at ESHRE, RCOG, paper presentations at national and regional conferences, chapter contributions in national and international books, ISAR, Foxy Consensus, articles and research work in journals, ISAR Express Committee news releases. Welcome, Dr. Ekika.
Thank you. Thank you.
Our next chairperson is Dr. Indu Kaul. She is ex-HOD and Professor of Obs and Gynae, ex-member Governing Body AIMS Patna since July 2013-21, Secretary ISAR Jammu and Kashmir Chapter. Welcome, Dr. Indu. So, over to you, chairpersons.
Okay, chairpersons, please introduce Dr. Kedar.
I'll go ahead. So I welcome Dr. Kedar Ganla. His name needs no introduction, and man, he's one of the wonderful orator and a wonderful speaker. And everyone look forwards to his clinical apt presentations. This is what I personally feel for him. And besides that, I would like to introduce him as he's a consultant fertility physician, MSR secretary. He had been joint secretary MOGS, past ISAR honorary secretary journal, practicing for last 28 years and more than 25 national and international publications, more than 500 invited talks. So looking forward eagerly to listen to Dr. Kedar for a very important topic, which is a very routine topic for most of us. Thank you, Dr. Kedar.
Slides are visible. Please make it slideshow, Kedar.
So you are on mute. Kedar,
Yeah,
sir, you are
Kedar,
on
we're
mute.
not able to.
Kedar, we could not hear you.
okay,
Yeah,
okay.
we can.
Okay, can you see now
Yes, we can see
Yes,
you and hear
now
you.
see and hear.
my slides? Now the slides.
Yes. Yes. Same.
Okay, seen, no?
Yes, Kedar.
1 minute, huh? Some jumbled I have done. 1 minute. I'll start again.
Is it a video?
No. What is this? Okay.
Stop. We are seeing your slides and hearing you.
But I cannot see my own slides.
Uh-oh. I think you have to open the Zoom.
Okay,
Zoom must have been as well.
I've seen my slides. Okay. This is one of my favorite topics, gonadotropin and IUI, and I always wonder Why do the general OBGYN, especially in our side of town or India, have very difficult time in convincing to use gonadotrophins for IUI? The most important aspect of this is what is the principle of your ovulation induction. In an ovulatory patient, you want only single follicle. Ovulatory patients, that is unexplained male infertility, endometriosis, 2 to 3 follicles, to get the pregnancy in a shortest period of time with reduction in OHSS and multiple pregnancy. So this is ovulation induction in oligoovulatory patient, ovulation augmentation. And what is the ovulation augmentation? Is more than one follicle, so it should be up to 3 follicle, which corrects the subtle luteal phase defect. At the same time, gives you endometrium, which is more than 7 millimeter. So this is what happens to your patients. So you go for clomiphene citrate, 1 cycle fails, second cycle fails, then the third cycle fails, and then the patient leaves you and goes to the next gynecologist. So hypogonadism, CC resistant patient who do not respond to clomiphene citrate, CC failure, patient who have taken clomiphene for 6 cycles, thin endometrium where you cannot use or should not use clomiphene citrate, elderly woman with low ovarian reserve, mild to moderate male factor infertility where the total motile count is more than 5 million, grade 1, grade 2 endometriosis where you instead of using letrozole use HMG for higher pregnancy, the most important unexplained infertility. So this particular result shows in unexplained infertility when you use gonadotrophin stimulation in IUI and a cumulative pregnancy rate, you get higher cumulative pregnancy rate and high live birth rate. So IUI for meta-analysis, it shows that it clearly shows that gonadotrophin gives higher ongoing pregnancy and live birth rate as compared to letrozole clomiphene. Now, do we require a pre-gonadotrophin evaluation and why? Why? Because gonadotrophin stimulation is expensive with potential side effect and you will not be able to say that it's going to get 100% result. So recently done semen analysis, those who have a referral center where you get a lot of patients for IUI, you will say that outside report says 50 million, but when they give semen sample to your clinic, it is actually 5 million. So this patient should have been taken up for something else. So I always go by total motile sperm count. If it's more than 5 million, then only go for superovulation and IUI. Then comes pre-gonadotrophin tubal evaluation. I generally prefer laparoscopy rather than using HSG, and ovarian factors like antral follicle count, endocrine, TSH, prolactin, and one natural cycle follicular studies to look at the endometrial thickness and evaluating endometrial pathologies. Sometimes you start gonadotrophin stimulation and a polyp starts coming up, and then you might have to do a hysteroscopy. Now, how do you go about? It can be letrozole gonadotrophin stimulation, where the gonadotrophin are started 1 day after the clomiphene or after the last dose of letrozole, and then ultrasound is done after 3 days. So combination of this gives you higher pregnancy rate, low abortion rate, and reduces the cost of the therapy, as has been shown in this particular paper, that your endometrial thickness is high and cumulative pregnancy rates are on the higher side. So another paper, again letrozole followed by FSH, and you get less number of ampules of FSH use, less number of cancellation of cycles, and good clinical pregnancy outcome. So the dosage use is less and risk of hyperstimulation goes down because letrozole improves follicular sensitivity to FSH and endometrial thickness is achieved because of high levels of E2. And another paper which talks about retrospective analysis of three types of IUI: natural cycle with letrozole and letrozole HMG. So you give day 2 to day 6 letrozole or 5 milligram letrozole, and then you do IUI. Or the third group, you give letrozole 2.5 to 5 milligram followed by HMG for the time till it becomes 18 millimeter. Look at the pregnancy rate. The pregnancy rate can be as high as 17% with live birth rate of 14% when you use gonadotropin stimulation. But my little bit worry is that multiple pregnancy. And I think now multiple pregnancy are more happening in IUI cycles than IVF because they have realized putting single blastocyst gives a equally same pregnancy rate. So it improves the follicular development, endometrial thickness, and live birth rate. Daily versus alternate day. I completely disagree that alternate day should be given to reduce the cost of the therapy. It just doesn't work. Neither the same ampules can be used on the next day. Between the HMG and FSH preparation, all meta-analysis have concluded everything is same, especially in terms of IUI, and one should look at the availability and the cost and the convenience. So HMG and FSH both gives clinically same pregnancy rate, no increase in live birth rate or OHSS. So how do you decide the starting dose of gonadotropin? This is very, very important for all the beginners, and this all depends upon the age of the patient, AMH, AFC, and BMI. On day 2 or day 3 of the period, rule out TVS, ovarian cyst. If required E2, ask these 4 questions. As the patient has got previous OHSS, if yes, at what dose? Then you start with the lower dose. Younger the patient, higher the chance. Higher the AMH, higher the AFC, higher chance. If the ovary is PCO, then higher chance of OHSS and hyper response. But using simple chart like this, that is the total antral follicle count on the weight, one can decide the starting dose of HMG. So let's take an example, antral follicle count of 15 and the weight of the patient is, weight of the patient is 65, your starting dose should be 75. If the weight of the patient is 85, your starting dose would have been for antral follicle count of 15 would be 100 IU. So that's how the BMI is taken into the consideration. So when you do a step up protocol, which is a very, very easy protocol for the beginners, you start with 37.5, 50 IU in a tight PCO patient, and unexplained infertility patient maybe 75 IU. And then you go to a level of 10 to 12 millimeter where 1 or 2 follicles will come up, and there you step up the dose to little higher dose to allow the other 2 follicles to continue, and rest of the follicles will fall down. For beginners, step up protocol is the best protocol. Then step down protocol is the one which we use in IVF, high dose in the beginning, have the good recruitment, and then subsequently reduce the dose so that the smaller follicles will fall down, and that will help. But only in step down protocol, if you miss the critical level of 10 to 12 millimeters to step down, you may land up with the hyper response. This is chronic low dose protocol for IVF cycle. No, this is not the one. So this is a chronic low dose protocol where this is a typical Australian protocol where they use a low dose for 14 days. Then they step up only by 37.5 or 50%, and then again continue for 7 days and then continue for 7 days. This gives a very, very good pregnancy rate, monofolliculogenesis, and less than 1% of multiple pregnancy. So how do you monitor the cycle? And is there a role of hormonal evaluation? The monitoring of the cycle is ultrasound, ultrasound, and ultrasound. So day 2 and day 3, you do the scan and then you start your stimulation. And day 5, day 6, you see the scan and look at the endometrial thickness and the follicular phase. One can do an E2 if you want to be accurately judging the treatment. But as the experience progresses, you may need to stop. So by doing ultrasound, residual follicle, day 5 of stimulation, see the response, and depending upon that, every 2 to 3 days. Only estradiol and progesterone to be done, E2 to be done when you have given 14 days or 18 days of hormonal treatment. There has been no recruitment. You can do E2 to show the patient. See, after giving so many days of injections, your E2 is not grown, means which is correspond to the follicles. You may have to drop the cycle and start next cycle with little higher dose, or when the size of the follicle is or more than 4 to 5 follicles on each side, potentially patient is going for hyperstimulation. That when you want to cancel the cycle, you can do E2. Progesterone, I will keep it up only for 2 or 3 failed IUI cycle. On the day of the SCG, I will do the progesterone to detect premature LS surge. If that is the case, then the next cycle I will add the antagonist. So hyperstimulation, what are the options? Can you cancel the cycle? What advice do you give? Or convert to the IVF? Was the patient counseled beforehand? And what is the facility and cost and implication? So the question is, by chance, if you send a patient to a radiologist, radiologists do the scans from the transabdominal scan, and for them, multiple small follicles starts from 12 and 14 millimeter onwards. So you will not come to know when the big cohort is coming up for hyperstimulation, and one fine day you will find you will step up the dose and the patient has 10 follicles on each side. Now, converting on the IVF side is a very critical question. If you have a center nearby, call them up. They will tell you the protocol to add antagonist and send them the patient, and they will convert into a IVF and freeze their embryos, which can be used later on. But here the cost implication can come into the picture, and the counseling of the patient beforehand. So, or if you are going to cancel the cycle, one must remember to tell the patient not to have intercourse, because natural LS surge still can happen and they can have multiple pregnancy. So OHSS prevention is not to give SCG injection at all for this patient, and one can add GnRH analog to prevent LS surge. So difficulty is in gonadotropin, or disadvantage is that affordability, because the cost is high, frequent visits, which is very difficult for patient who is staying away from the metropolitan city, no response, that is something difficult, LH surge, and two dreaded complication, OHSS and multiple pregnancy, which this we have overcome quite a bit. This is growing by hop and bump. So when do you cancel the cycle? There is no recruitment of the follicle, or there are 3 to 4 follicles, and when you E2 is more than 1200, this is just to prevent multiple pregnancy. At this point, one should ask a patient that you are heading for multiple pregnancy, and are you willing for it? And if they are not willing for it, then cancel the cycle. And more than 4 to 5 follicles on each side with E2 more than 3000, maybe you are heading for hyperstimulation. So in luteal phase, multiple follicles, supraphysiological estrogen, progesterone, FSHLS suppression, luteolytic effect. So gonadotropin stimulation always helps by giving vaginal progesterone for luteal phase support. The patient should come on day 2, day 3 of the cycle, ultrasound to rule out ovarian cyst. If required, do E2, adjust the dose, slow and steady, depending upon the age of the patient, type of the ovary, AMH, and past history of OHSS. use gonadotropin only if you have proper monitoring facilities, that is blood levels and also ultrasound. Start with one type of protocol, that is step up protocol or letrozole with HMG, softer protocol. At the same time, do not use multiple protocols. Get familiar with one. Be practical in increasing the dose. So what happens after 7 days, patient is sitting in your consulting room and you have seen no response, you will tend to increase the dose by double. The doubling has to be done by 30 to 50%. In this case, multi-dose vials are very, very useful. Sometimes when you step up by 50%, you may get sudden explosive response. Always give 3 to 4 days and then monitor again for a response. No matter how careful you are, OHS is likely to going to happen, and the response of HMG is going to vary from cycle to cycle in same patient and in patient to patient in the same batch of gonadotropin. Gonadotropin always maintained a cold chain. Now, especially when the SCG doesn't work and the SCG is bought from the chemist, because the cold chain is not maintained. I always prescribe subcutaneous injection to reduce the discomfort and self administration of the drug, preferably at the same time. And if powder and water is mixed and use half of the dose, the other half should be thrown because it doesn't work. I think this video is something which is very useful. If I get time, can I play the video? This is a man who is very old, and during Christmas time, is doing some weightlifting the most beautiful part. He has come to his granddaughter's house to meet her at the Christmas time. Only for this. Only for this. He has been practicing for so many days. I think if you are going to be the gynecologist who wants to really use HMG, I think one needs to practice sometime in the other and enter this league as soon as possible. This I'm going to skip, and the next slide is going to be a little different. So hyperstimulation happens. May what come, I think you need to contact your local IVF guy and take their help. But most important for me, this is something which is very, very important. Clomiphene cited 5 to 10%, letrozole 5 to 10%. Conventional IVF is 20 to 30%. You know what is the natural twin pregnancy rate? Can you guesses? Only 1%. This is iatrogenic epidemic of multiple pregnancy. Because of us, there are so many NICUs are thriving now, thriving only because of us. And that's because the multiple pregnancy. Look at this twin pregnancy, average weight of delivery gestational age is 35, 5 times risk of cerebral palsy, and death at the end of 1 year is 7 times higher. Only with twins. I'm not even going to triplet, only with twin pregnancy. So I think average LICU stay is 18 days. 18 days means 10,000 per day, means around 2 lakh rupees. And the same patient when he was getting stimulated for AID, he did not have 10,000 rupees to pay you. I think good. This is what the patient came to you for. What is for to have a baby, and we decided to give them babies. And this is the worst thing: severe OHSS with discordant twins in NICU. Let me end with this wonderful video. So we are giving them two beautiful angels, and you talk to the wife after 5 years. Her entire life, physical, mental, social, psychological, financial, is completely destroyed by the end of 5 years. So, ladies and gentlemen, I really request you to think about this. Thank you very much for giving me this opportunity.
Thank you, Kedar.
Dr. Kedar.
Over to you, chairpersons.
Thank you, Dr. Kedar.
Yeah.
It has been, it's being given in a very simplified way, the way you have mentioned all the gonadotrophin in IUI. So there are few things which I wanted to ask you. I mean, for a simple gynecologist, if she has decided to start using the gonadotrophins for you, according to you, HMG at the what minimum dose? Will it be better for them to start it from 37.5 or 75? Though you have shown me the chart, I mean, there's the beautiful way of calculating it, but still for them, they want to know, I mean, can they start with 75? And what if she's very obese with high LH and high AMH? So in that cases, what should be done?
Ekika, on the first day of the labor ward round, we went and did a PV and we did not understand anything. Okay. So we
Yep.
followed the register, and after 6 months, we started understanding it is antiverted, retroverted. अभी तक मुझे समझता नहीं है वो. So what you do, I suggest them that you do the recording of your scan and send it to me, and then we discuss the at least first few cycles, so that you will not face a failure. Okay, that is a one simple way of doing it. Second, if you are going to give letrozole, after giving letrozole, you see the response, because they are going to use it for the first time, so they have to be very careful. And on day 7, after the scan, depending upon the size of the follicle and number of follicle, they should decide the dose of HMG. Now, our highly purified HMG, don't think so 37.5 is the starting dose, would be sufficient. 50 is the one which is very good. And if the patient is obese, then the 100 IU should be quite
Use.
sufficient for 4 days, and then go ahead with next scan.
So probably with IUI, I mean with HMG or gonadotrophins, when they are doing, first and foremost, they should know at least how to do a TVS themselves to be more
Yes,
confident.
yes,
And secondly, at least after 4 days, they should review the growth and then decide whether she have to go up to the dose or she has to reduce the dose. And thirdly, she should not have any fear. And the refrigeration of gonadotrophins are very important when you're using them in-house, where to keep them.
absolutely.
That's it. That's okay. So thank you, sir. It was nice. Once again, very nice hearing you. I keep hearing you again and again. I really love it, the way you explain things.
Thank
And
you.
that's it, sir. Thank you very much for a very
Thank you.
crystal clear message to be given to everyone around.
Thank you so much for inviting me. Thank you.
The
Thank you,
other
sir. Thank you very
chairpersons,
much.
any questions? I think
No questions.
you are perfectly clear and I mean perfect to the correct to the message was given. That's why.
Hello guys, though I'm not a chairperson, can I ask Kedar sir one question?
हाँ, go ahead, go ahead.
Sachin?
बदला
Kedar-
तू तो बदला लेगा ही अभी.
नहीं सर, आपके पास से बहुत सीखा है.
बोलो
And
ना.
your sildenafil for twisted ovarian cyst works superb.
Thank you.
So, sir, what proportion of IUIs that you are doing would be just letrozole or CC, and what proportion would be letrozole or CC plus HMG?
To be very honest, Sachin, I don't do a single IUI without HMG.
Okay,
No IUI on letrozole or CC. IUI has to be done only on gonadotrophins.
perfect.
Then only I think you get those high clinical pregnancy rate, which you
Okay.
and me maintain it as compared to the gynecologists. I keep seeing them sending the letrozole, one follicle, and the endometrium is not grown, and they are doing the IUI, and the same patient comes to you with 5 cycles of IUI done, but they are not done properly
Agree.
because they have not used gonadotropin and they are wasting the cycles. So I think this is what needs to be corrected.
HMG or REC FSH?
HMG.
75, 150.
75. Starting
70.
dose 75, but elderly lady with low antral follicle count and obese, I tend to use 100 or 150.
Then I just want to ask one thing since this point was brought out. This chronic low dose and all, whether you reserve only for very few patients or whether you routinely do it, because the stimulation goes for 20 days, 40 days. Even though it is told in the almost all the talks about wherever you hear, but practically how many in India, in Europe, they cannot go to any other place. They'll be here when we start doing chronic low dose. In a real PCO patient, it may last up to more 30 days or something. So practically, what is the message you can give to the audience?
I think better than that would be adding little letrozole in the
Yes,
initial phase
Initial
and
phase.
then adding low dose
correct,
would
correct.
be better, I think, rather
Yeah.
than starting or even Sachin says no, even after you given 5 days, on the 6th day you scan and you see no recruitment at all. It is better to give 2 more days of letrozole and call them on the 7th day. Again scan till the time little recruitment happens, at least 10 millimeter size follicle starts coming up. Then
Then you start gonadotropin.
then
Uh,
you start the gonadotropin.
Fesi
Since this
sir,
message
just
was told, I want to ask Sachin that maximum how much days of extended you are given? 10 days or whether now there are studies more than that, very few studies, that's why. But I have given only up to 10 days.
sir, I had a patient who got letrozole for 25 days, ovulated and conceived. This was the patient who needed laparoscopic ovarian drilling, but was not willing for that, was not willing for injectable gonadotropin. Now, I have started going back to, you have those big, bulky PCO ovaries where, they just don't respond to whatever you give. And you might just be scared that if you eat gonadotropin, she'll just blast off. These are the patients who have a high LH, AMH more than 7, 8, 9, big bulky PCO with volumes of 14, 16, 20. I've started doing a ovarian drilling for them. And trust me, excellent results if it is done well. Only thing is when you do the drilling, immediately the ovary has to be washed with saline. That reduces the temperature. And the FFH LH ratio comes to normal. The PCO comes to normal, and these women begin to ovulate on their own. So now again, for those women who don't want to go for gonadotropins or IUI, IVF, this is working well. But only it should be a pre-surgical decision with all the things,
Heather
not
want to add something.
not an intraoperative decision.
Heather?
Obese PCO will respond excellently to letrozole.
Yes.
Yes, sir.
Thin,
Thin
lean
PCO.
PCO with high androgen, high LH, low FSH patient will tend to less respond to letrozole. This is a patient who will respond to your 3 cycles of OC pills and the new drug which is launched, PCO Cure, I think, which has astaxanthin, resveratrol, and curcumin. I think I've used in 2 patients, and it is shown that the androgen levels fall down dramatically very fast. As far as the PCO drilling is concerned, general rule to be followed is the rule of 4 or rule of 5. I think one should not think that I think there are many follicles and I should puncture 10 holes. That is
Absolutely.
where things went wrong. Follow the guidelines to the core. 5 means 5. That's all. And
That is
that's
true.
what.
But in really bulky ovary, just by 4 millimeter may not be enough. The drill, I mean, the raw area must be minimum. But in really bulky ovary, just like Sachin told, we have to cauterize little more, not for the 4 seconds. Nothing will happen with that.
Anju will now. I think Anju is going to come out of the camera and going to tell me and Sachin. Now keep quiet. Okay, Baba, leaving. Thank you so much.
Wonderful discussion. But our panel is waiting and time is less.
Yeah.
So,
Thank you.
Okay, Anu, carry on with the
Thank you.
introduction.
Thank you very much.
Thank you, Anu. Thank you, Anu.
Thank you. Thank you.
thanks a
Thank you,
lot.
sir.
Thanks a
Thank you,
lot. And
Dr.
wonderful
Kedar. Thank you,
lectures.
Sachin.
Pleasure.
Good to always be in a tug of situation with Sachin when it comes to the ideas. But it's nice to have somebody who can, keep thinking and doing something novel and present.
Thank you, Ekika.
You
Thank you
must
so
do
much.
your studies. You must start doing your studies to present them. I mean, more authentically, so that all of us say, yes, what Sachin Baba is saying, that's right.
Sure, I'll do that.
Okay.
Thanks, Ekika.
Thank you, Anu. Thank you very much. Thank you, Anu.
Thanks. Thank you. So
Thank you.
now we'll move ahead towards our much awaited panel discussion by Dr. Kaberi, Enhancing IVF Success, Strategies for Managing Challenging Conditions. So I would like to invite Dr. Kaberi. We all know her. She's Medical Director, Advanced Fertility and Gynecological Center, New Delhi. Dr. Kaberi, welcome, Dr. Kaberi. So would you like to invite your panelists, Dr. Kaberi?
Sure. Thank you once again, ISAR, for this wonderful opportunity. And let me start by inviting my panelist, Dr. Anju Kanogia. She's the Director and Consultant at Ashirvad IVF Fertility, Jaunpur. May I have the next panelist? Dr. Pratibha Singh. She's the Senior Consultant in Fertility and Laparoscopic Robotic Surgeon at Lucknow. Dr. Saroja, she's the Senior Consultant and Clinical Director, Nova IVF. And Dr. Richa Singh from Lucknow, Director. Somebody needs to silent their...
I request Dr. Anju, please. Yeah.
Thank you. Dr. Richa Singh, Director, Urvava Fertility Center, Lucknow. Dr. Ishita, Director, Upahar Nursing Home, Varanasi. Dr. Shweta, she is the, there's a lot written here. I think she's at the moment working at Nagpur Test Tube Baby Center, if I'm not mistaken. Yes, she's from Nagpur. Welcome, Dr. Shweta.
Thank you, madam.
Right, so I have the sharing rights, yeah. So though today we are going to discuss the difficult clinical scenario in IVF and how we can enhance its success rate, we will start with a simple question first. And I would like to know who all of my panelists do not do IVF. Hello?
All please respond. If possible, all panel members, please on the camera. Signal is good.
So I presume all of you would either be doing or have a good knowledge of IVF. So this is a 27-year-old lady with 3 years of primary infertility. She is visiting your fertility clinic with laparoscopic findings of bilateral tubal block. All other investigations are normal and you've decided to go ahead with IVF. What factors would you double check to ensure that she has the best results? So what would be your preliminary basic tests? So I would request Dr. Anju to share her thoughts.
First of all, I would like to whether she is physical active or not,
what is her BMI, and I want to know her lifestyle, and what is ovarian reserve, about her AFC, semen analysis of male partner, and rule out infections. Check mid-cycle ET also.
Right. So the reason we have put this slide is to, before we start on IVF and try to deal with the complicating scenario, our basic fundamentals must be clear. We should be sure that her endometrium is good, her ovarian reserve is reasonable, semen analysis, there's not much of motility, morphology, oats, and infection, fibroid, hydrosalpinges must be ruled out. So this would be a typical very good case where we would be expecting a good result. One thing about the mid-cycle endometrium, and this we will come in the next question, and perhaps let's go straight on to that to take. And now I will be asking Dr. Pratibha, how do you tackle thin endometrium in your practice? Before you answer that, what, according to you, is thin endometrium and how will you diagnose it?
If endometrium is less than 5 millimeter in the mid cycle, or if it is not a triple line or vascularity flow is less, then we can say it is a thin endometrium.
Any of my panelists would like
I would
to
like to
add?
correct, as per the definition, it is 7 mm as the criteria in the mid cycle. If it is not reached till 7 mm, then we call it as thin endometrium, and that's how we diagnose. So mid cycle, we have to really evaluate the endometrial lining.
Yes, so I would agree with that, that most studies are saying 7 millimeters, though some have gone down to 6. And one thing very, very important, that it has to be a natural cycle, meaning you should ensure that the patient is not on any medications, has not taken any medications in the previous cycle, like contraceptive pills, clomiphene citrate, and on such a cycle, her lining must be measured. So, Dr. Saroja, how do you usually prepare the endometrium? Say we are talking, let's go to core IVF and you're preparing a frozen embryo transfer cycle. What is your usual protocol for preparation?
So first of all, we would assess like how the endometrium was like when we were simulating the cycle, or when we initially assessed if there was any problem with the endometrium or not. If the endometrium was good and no problems, we'll just start with the preparation. If there was any problems like beforehand, if the endometrium was thin or if there was any doubt regarding the endometrium, then I would do a hysteroscopy. If everything is fine, then I would do, majority of my cycles would be HRT cycles. But if there is like a resistant to HRT cycles, we will go with ovulation induction HRT. And if they have adenomyosis or something, I will give like down-regulated HRT.
So what molecule do you prefer? What is the route and what is the maximum dose that you usually go up to?
So we give like estradiol hemihydrate as a vaginal route, and we give estradiol as a oral route too. So we give a combination of like oral, like majority of the patients we give 4 milligram BD and see how the endometrium is. Majority of the people respond, but if there are like diabetic or if there are elderly patients, we give mostly through the vaginal route.
So you start on day 1, day 2 with 8
Day
milligrams.
2.
Is that what
Yeah,
you?
yeah. Yes,
Oh.
yes.
Dr. Shweta, Dr. Meeta, do you have anything to say on this? Your usual protocol for preparing the endometrium?
Yeah, ma'am. Actually, if most of the times we use a HRT protocol, and we start with a oral dose of 2 milligram twice, 4 milligram thrice daily first, and then we increase, and the maximum dosage of estradiol, if required, mostly we give 8 milligram a day, but we can increase up to 12 if required. But most of the patients, they respond to 8 milligrams.
And if the patient, we feel that in previous cycles or some problem with HRT protocol, then sometimes natural protocols or modified stimulated protocols also work for these patients if they are not responding to usual HRT protocols.
Right. So usually we would start with the slightly low dose, maybe 2 milligram twice or thrice, and then if needed, increase from the 6th or 7th day. That's the usual protocol, and we can start with 4 to 6 and go up to maximum 12, and that's the recommended dose. And natural cycle is a very good alternative way of even starting off your FET cycles. And I think Dr. Ishita is not with us today. Right. So, Dr. Meeta, what other protocols apart from the HRT and the natural protocol do you follow?
Sometimes we can use tamoxifen if we are having thin endometrium in previous cycles. So we can use tamoxifen stimulated cycles also. Some patients responds very well to that.
Letrozole, HMG stimulated cycles as well?
Yes, ma'am.
Okay. Dr. Anju, when would you like to scope a patient with thin endometrium, or would you always do that?
Ma'am, when the endometrium on day 9 is less than 6 centimeter, I call it thin endometrium, and I want to increase the dose of estradiol, validate.
No, my question is, when would
2
you
mg,
like to put in a hysteroscope in a patient of thin endometrium?
Yeah, ma'am. In next cycle, if patient is not responding, then I will do subendometrial PRP to increase the endometrium and some metroplasty. Endometrial scratching I will do.
Dr. Pratibha,
Hysteroscope.
do you have to say anything on this?
In a patient of thin endometrium, if we are not, in spite of increasing the dose of the estradiol, the endometrium is not growing, then we'll plan the patient for in next cycle for hysteroscopy, and we'll see for any additions or any endometrial pathology or infection or tuberculosis or something might be there. Because of that inflammatory condition also, endometrium is not growing. And also the patient, we inject some PRP or subendometrial PRP to increase the thickness of the endometrium in this cycle.
Right. So one of the diagnosis is adhesions, and it is not complete grade 4 adhesions that respond to hysteroscopic treatment, but the initial adhesions, 1, 2, or 3 bands, once you put in an hysteroscope and you remove those bands, you get a very good response in the next following cycle. So a hysteroscopy can be very, very useful in a case of thin endometrium. We did talk about... Yes,
Can I
please.
add something, Dr. Kabiri? Actually,
Sure.
we all discussed that we start with a smaller dose, say around 2 mg TDS, and then that's how we see on day 9 and day 10. I would like to add on a point here. In my clinical practice, in my first cycle, if I have given a dose and up to even the maximum doses, the patient is not responding, I would rather prefer a next cycle with a little higher dose of starting the preparation for the HRT. And if again the second cycle also with the maximum dose does not respond, then probably I would like to take a decision for hysteroscopy if the ET is not improving. So I think one cycle, if one cycle, there might be that some endometriums have a higher threshold of responsiveness. So you let us know what is your take and how you would like to take it forward.
I
That's a
want to
very
add a
valid,
point.
yeah, may I? That's a very valid point. I think there are 2 points here. One is, when would you scope? Would you wait for a few cycles before you put in a telescope? And second is, how would you increase the dosages? So in increasing the dose, not only can you start with the higher dose in the next cycle, I completely agree with that. You can also use different forms of estrogen, like
Definitely.
has been mentioned, a vaginal route or a gel route, which some patients, respond to those routes better. Also, you can, our particular clinical experience, and we've also published a paper on the adjuncts that are used, though all these are still in the, we need more trials and we need more studies, but we did compare subcutaneous GCSF and we found a significant improvement. PRP and stem cells, again in the clinical zone and experimental zone, which has to be explained to the patient. But there have been, so yes, there are various ways in which you can
Adjuncts.
still try to improve the endometrium, but most of the consensus, especially if it has been a failed cycle, a previous outside,
Yes.
then definitely hysteroscopy would be necessary. And thin endometrium, there has been quite a few studies that have said that if within a few cycles there's no improvement, hysteroscopy will help you in, we need to carry on. I'll take the next question with somebody who wanted to say something is, what is your opinion on nutraceuticals in thin endometrium?
It
Can I ask
increases the vascularity.
Richa or Shweta
Yeah.
on this?
So my take on nutraceuticals is that yes, I do use many times along with my estradiol hemihydrate if I'm giving up preparations, and if patients are not responding, I would like to add on to some adjuncts, but I usually prefer arginine because it has been observed that it increases the endometrial flow, and I've many times seen changes in the endometrial thickness. And some antioxidants can also be added, but personally in my practice I am not adding antioxidants. I usually add arginine sachets and increase the dose of the estradiol, and then let's see how the body behaves. And if sometimes it does not respond, then definitely we look forward to PRP or GCSF, intrauterine instillation.
Right. So we basically, the various modalities would be hysteroscopy if needed, the various routes of estrogen, the adjunct treatment, and PRP and stem cell. One of the very important things which may benefit the audience is this is when you are doing a routine embryo transfer cycle. You may or may not envisage thin endometrium in that, and start a cycle with a down regulation properly documented, either with low E2 or a baseline thin endometrium with no follicles. Even if there's a follicle, measure your estradiol, and if the estradiol is less than 60, only then start that cycle. Any cycle where there is any spotting or any fluid, please cancel that cycle. Do not use that cycle. Your transfer technique is very important in such cases. Persistently thin endometrium, we can go up to a few cycles with the various adjuncts that have been discussed. But at some point, we need to decide that enough has been tried and various options need to be given to our patients. Now we go to the very, very important, which most of us are facing in our practice, a 32-year-old with an AMH of 0.6. And my question to the panelists is, do all women, according to you, with low AMH behave the same? And she's very, very keen on self-egg IVF, as is with most of our patients. And what strategies will you keep in place to optimize her outcome? So can we start with Dr. Meeta, please?
Yes, ma'am. Nowadays, many patients, they are coming with low AMH and at this age, and I have seen many patients responding in a different ways, like with a zero point 0.5 AMH or 0.3 AMH. Some patients on stimulations, they may be producing more than 4 5 follicles. Some they are not responding at all, and some 1 to 2 follicles only. So, my stake on this low AMH patients are usually we should definitely give a try by stimulating them. And even if 3 4 follicles are developing, we should go ahead, and they might give a good number of embryos as well. 1 or 2 embryos at day 5 also maybe sometimes possible.
So what, according to you, is the most important prognostic factor?
Can I add on, Dr. Kabiri?
Let
Ma'am,
her
most
just,
Yeah,
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 one
yeah,
second.
sure, sure.
just 1 second. So I think comparing our ultrasound AFC on day 2 with the AMH is most important. Sometimes we see discrepancy on our ultrasounds, and then these patients they respond well.
Yes, you wanted to add on something?
Yeah. So what I wanted to add on is that every low AMH patient is not going to behave the same, because as per Poseidon criteria, we group people whether it is Poseidon 1, 2, 3, and 4. And age definitely plays a very important role, because in younger patients who are less than 35 years of age, we tend to have, even with low AMH, we tend to have better quality of embryos, and they have a better chances of conception. And it has been, various studies has been seen that they have better implantation rates, better clinical pregnancy rates, and lower cycle cancellations, and the lower miscarriages rate. So that is number one, that we have to understand and counsel the patient depending upon what her age is. And secondly, we just also have to see that if it is isolated low AMH, which is just 0.6, or there is an associated rise in the FSH and LH hormones, because if it is high, it is going to be a poor responder, and it has more chances of cycle cancellation. So in my opinion, I would like to first counsel the patient, number one. Number two, I would like to evaluate her. Apart from AMH, I would like to get her hormones done and see whether she is downregulated or not. And in the meantime, when I'm probably, if she's coming to me and in my mid cycle, and I'm planning her stimulation in the coming month, I would like to add on to some adjuvants to kind of increase her ovarian reserve or quality, or to better her cycle outcome.
Yeah, just let me hold on to you here, Richa. So very important point, age and AMH and AFC,
Yeah.
these are the basic things. And lower the age, higher is your prognosis, and the counseling must go that way. Also, when you do your ultrasound, there would be women who've had previous unilateral ovarian surgery, and the other ovary is absolutely fine, and her AMH is low. So these women have a better prognosis than any other woman with the same age with both ovaries, suboptimal. So single ovary working better will still have a better chance than with similar AMHs. So that is one important thing. The other thing which I feel we all as IVF, specialist must explain to our patient is the fertility pyramid, and whether it is low AMH or normo responders, that the number of follicles, because as we are doing the follicular scans, we see how anxious they are to look into the ultrasound machines and follicles, and somehow in their mind, for those who are not as experienced in the, maybe it's the first cycle or the second cycle, they would correlate follicles with perhaps embryos in the back of their mind. And it is very important to tell them again and again that follicles, eggs, embryos, day 5, good embryos, there's a downhill journey. And that's how we will reach to at least 1 or 2 good embryos to give you the good success rate. So this is something, and of course, we will now come to the important points, Richa, that you were discussing. So Saroja, can you please tell us what lifestyle measures would you look for specifically, and what would be your advices for them?
So I would advise like maintain the optimum weight. So do appropriate exercise to maintain your BMI below 25. Then appropriate diet, like with a balanced diet that you have to be. And if anybody is smoking, because smoking nowadays is quite common among women as well, so I'll ask them to stop smoking, because that can dramatically decrease the number of oocytes. And if they are taking alcohol or drugs, advise them to act against it and maintain a healthy lifestyle, decrease the stress as well, because stress also seems to play a role in decreasing the oocyte count. And also counsel them this might help. And even like if you get one more egg with all this, that will form a good embryo maybe.
Right. Now, here one point, Saroja, I want you to highlight in your clinical practice, when you say healthy lifestyle, what exactly do you tell? Because in nowadays, even with the PCOS guidelines, They are the SMART objectives, means they have to be
Yes,
specific
they
and they
should
have
be
to be
specific and
and
measurable.
measurable. Right.
So I would say,
So,
like, if it is like minimal exercise or moderate exercise or severe exercise, depending upon the type of exercise. If the depending if the if it is severe exercise, we can just ask them to do it 3 times a week. If it is moderate exercise, it depends upon the number of hours that we tell them.
right. So moderate would be, anywhere between brisk walking to running to swimming. And that has to be the duration that you've mentioned. We are practicing in Delhi, and I'm sure in most cities, most women have their smartwatch with them. And I tell them that the sedentary people, their step count won't be even 2,000 or 3,000 steps a day. So please increase it to at least 7,000 to 8,000, if not 10,000. And also give a specific pertaining meal plan, though it's not always mandatory to follow that, but at least it's a target they can look depending on their culture and whether they are vegetarian or non-vegetarians. Now, Anju, what is your opinion on various supplements that are used in these women? What do you use, and what is your clinical experience on their outcome?
Ma'am, I usually use folic acid and vitamin E or vitamin C, coenzyme Q, and nowadays also using EQOQ for better response.
How long do you give it?
Ma'am, I start just as a pre-treatment and for continue till embryo transfer, and also after pregnancy is positive, then also continue for 12 weeks onwards.
Shweta, do you have to add anything on this?
Madam, I would like to add DHEA supplement for at least 3 months. That is 75 milligram OD in OD dose. We can add melatonin in low dose, like say 5 milligram OD, which are nowadays in combination with DHEAs, they are available. I would specifically like to add vitamin D supplement that should be 60,000 international units weekly for at least 6 weeks. It would be better to add vitamin D supplements after testing, but considering Indians being deficient in vitamin D, like say 98-99% of population is deficient. So we can add vitamin D even without testing. And CoQ10 supplement, coenzyme Q10 supplement, 300 milligram OD for 2 to 3 months at least should be given for a patient of low AMH to anticipate and to expect and to have a good effect of antioxidant on AMH, or if not AMH, we can expect good quality of oocyte retrieval during pickups with these supplements.
Right. So the data on DHEA and CoQ10 is, coming up in a big way. And we will just come to the various dosages and all have been mentioned already. The fertility option, Dr. Pratibha. So this lady, she was, what was her age? I think she was in her 30s.
32.
32. What is your personal opinion on offering IUI to these women who have a decent sperm count, the tubes are open? Would you, in a women with low AMH, offer that first before going to IVF?
In a patient of low AMH patient, there is very less chances of going for natural conception or IUI. I also have done many in patient, but the results are not very good because the quality of oocytes are also very poor in the patients of low AMH. So we have to consult the patient for embryo pooling also, and we give double stimulation and we'll pool the embryo and we'll go for IVF only. We don't want to give a trial of IUI in a patient of very low AMH.
Yeah, I would tend to agree to that because time is of essence. And the way I explain to the patients is that your AMH may be, downhill curve, maybe, we don't know. And it is best to utilize the most effective fertility option initially. Whether we get the result or not, we don't know. But at least we should not wait till it has gone further down and your chances will become less than what it is today. However,
Yes,
still patients would sometimes insist on going on less invasive ART methods, and a few cycles, 1 to 2 cycles, is something that we may consider if the patient insists. And few studies, very few, most are saying IVF is better than IUI, but some studies have said that IUI may also be effective. Now, this is the protocol, and Saroja and Richa, I will take both your opinions on your personal experience of which protocol you like to use in these women. First, Saroja, can I hear from you?
I'll go with the antagonist protocol, madam, because I'm using it a lot. So I'll preferably go with the antagonist protocol. And I've seen good results with the antagon protocol.
Okay. So what drug and what dose?
So usually I decide the dose depending upon the age. Obviously, this patient age is 32. Depending upon the duration of fertility and depending upon her BMI and looking at the previous response, how she has responded. So majority of my patients in UK, when I worked, we used to give 150 and they used to really have a good response. But here I don't see that response. So I start with 300 units.
And is it HMG or FSH?
HMG, ma'am.
Okay.
And it doesn't
Richa?
matter
Yeah.
his HMG or recombinant FSH. It doesn't matter.
So, Dr. Kabiri, I was actually using antagonist protocol till last 1.5 years back. Since then, I have switched on to PPOS protocols. And what I have seen in my practice is that PPOS protocols are actually giving us better results, better M2s, and the overall the burden of the citrulix and the antagonist injections have gone down. And regarding the starting dose of the gonadotropins, I would usually start with 300 recombinant FSH. And depending upon her baseline E2 and LH and FSH, we have to see whether she is hypo or what is the situation there. And if she's elderly, maybe more than 35, I might add on to 75 units of LH to have a better result. This is how I start, and from day 2 we start with the progesterone down regulation.
Right. Shweta, what is your opinion on the agonist cycle for poor responders?
Madam, I've seen, uh, uh, I mean, in my experience also, as well as the trials which we read, that stimulation with antagonist protocol or stimulation with GnRH agonist protocol, long dose protocol, or giving ovulagens with gonadotropins, all the protocols give similar results and they all are equal as far as M2 oocyte retrieval is considered.
Right. There have been some studies that have recently shown that agonist cycles in poor responders may give us slightly better response. But like my panelists, even we start with the antagonist cycle. And if that hasn't worked well, we go to an agonist cycle. We do add growth hormone and, sometimes the flare protocol also. So we are, anybody here does duostim because we don't do it. We tried it, we didn't like it, we stopped it. So any of my panelists are still doing it, and what is their experience on it?
Madam, I have done duostim, but duostim, I personally also didn't find it very useful. As well as the ESHRE guidelines of 2022, they also recommended that duostim shouldn't be done.
Right.
So,
Now,
we also did in 2-3 patients dual stim, but we felt like Futia from the first cycle was interfering and the patient was having discomfort. Not a good experience doing dual stim for me.
I have
See, in
also
the
not good
Hmm.
experience, ma'am, regarding
Hmm.
dual stimulation. We don't get much result. It's better to stimulate in next cycle, and you will get good quality of the cohort than stimulating in the same cycle. It's not giving good results.
Yeah, I think so. We all agree in it that our experience with the Duostim has not been as good as we were expecting it to be. Now, the other thing, there's a beautiful paper on Duostim which has done a SWOT analysis of it, and in which they have given that one of the weaknesses of the Duostim strategy is that you are actually, even though you've done your pickup and then you are starting your stimulation in a few days' time, the second one, when you started in 4 or 5 days, sometimes there's a withdrawal bleed also. So whether the duostem is actually follicular and luteal or actual two follicular very close together is also a big question mark. So yeah, so we let it be that the experience so far hasn't been very promising. Now, this is my favorite, and we are doing a lot of embryo pooling in our unit. I would like to hear from Meeta, Richa, and anybody else. So let's start with Meeta. Do you do embryo pooling? And if so, what are the stimulation protocols that you use? And when do you transfer these embryos?
Yeah, ma'am, we are doing embryo pooling, and in many patients we are doing. So, if in first cycle we got a good response with the intact protocol, so in the repeat cycle also we use the same protocol, and at the end, if we after doing 2 or 3 stimulations, if we get good number of embryos on day 5. Sometimes we have to freeze in first cycle if we have to freeze on day 3, and then in the next cycle again we have to if we get some 2 or 3 embryos on day 3, then we can take all the embryos together to day 5, and on day 5 if we get 2 embryos minimum of good grade, then we go for the transfer in the next cycle.
Right. So the aim is to get at least 1 or 2 embryos of good grading. And if you get it in your first cycle, there is no need to do the pooling. You may even transfer to get. This is the consensus nowadays that if you're getting initially good embryos, even if the numbers are less, it's better to transfer. But even if you're not getting good enough embryos, it is better to go to the next cycle stimulation and then transfer in the second cycle. One thing that I've realized about embryo pooling is your counseling of the patients in the first meeting is very, very important. And once they are well counseled, then conversion to the next EP2 is very easy and smooth. But if you tell them on the day of egg cup or embryo formation that it's not good, we'd like to do once again, then it's met with a lot of resistance and disappointment. So, anything else that my panelists would like to add here about their experience of embryo pooling?
Ma'am, some patients have told like we'll do 2 cycles, even though they get 1 or 2 good embryos in the first cycle, they want to go ahead with another cycle so that they can use for further pregnancies, like even after the first child. So I agree with them because the reserve might further, like after they have child, deliver after 1 or 2 years, it might go down even more.
Yes, I would agree with that.
Ma'am, I will like to add something. If we are stimulating low AMH patients, the counseling is very important because the chances of cycle cancellations are also there. So we should counsel the patient at the first meeting only that definitely we are going to try. There may be cycle cancellations at any point of time. And if we get some embryos, then definitely we may have to go for embryo pooling to get a good success rate.
I think this is a very, very important point that you have to explain response to stimulation will be judged. Once it is good, then we move to egg pickup. If we get M2s, then we wait for embryo formation. So very well, very important point, Meeta taken. Yes, Richa or Pratibha,
Yeah,
you were
I
trying
wanted to add that first cycle we are giving conventional stimulation to the patients, and if we are getting good embryos, then second cycle definitely conventional stimulation is suggested. But if suppose we have an antral follicle count of say around 4 and 5, and out of all the conventional stimulations, we are only getting maybe 1 or 2 M2s, and we are just able to make only 1 embryo. So I would prefer a minimal stimulation cycle in a next pooling, so that her drug dosages are less, because in any which ways we are going to get 1 or 2 embryos only. So that is how I rationalize and kind of try to bring down the cost of the treatment also, depending upon how well her first cycle has responded.
Very valid point. Very valid point is that the stimulation protocol needs to be judged according to the response of the patient and your particular unit performance on the various stimulation protocols. And what we have seen is that, like I mentioned earlier, we do back to back. So we have antagonist, agonist, and then maybe a minimal or a flare. And in some women, and we are trying to, this is in publication process, in some patients, we have seen subsequent cycles have given us a better results than before.
Yes.
So I don't know if that is a finding of my colleagues as well.
Yes, definitely. We have seen that our second cycles have better embryos as compared to the first cycle. Maybe that we have been putting them on supplementations and the nutraceuticals to kind of increase our ovarian reserves and the quality of the eggs that we get. And I think majority of them have better embryos in a second cycle as compared to the first one.
Wonderful. I think we need to move on. So now, so let's ask Anju and Pratibha, what is your opinion on PRP and stem cell in these women? When do you do it? And if you do it, when do you do it? And how do you do it? So
In
Anju can
cases of
start. Yeah, Pratibha, please carry on.
in cases of low AMH, we use ovarian PRP, but I have never tried for stem cells, but results are not very optimal even after PRP. Also, in cases of low AMH, it is still in experimental, and so I don't try much ovarian PRP in cases of low AMH.
Dr. Anju, what is your experience in this? So anybody else would like to comment on this?
So patients who are in the perimenopausal age group, or basically I limitize my patients till less than 42 or 43 years of age, 37 to 42, 43 bracket. And there we discuss about the ovarian PRP, but we do tell them about the success rates, because as Dr. Pratibha said, it's still in the experimental phase. Many of the patients do respond and many of the patients still do not respond. So we first take them on the, we take first cycle of PRP with them, and give them on medications for the 3 months. Then we again review. If there is a response, we go ahead for the second session. If there is no response, then a proper discussion is being done. Patient still wants to pursue, we go for the second cycle. But personally, in my experience, after 2 sittings of PRP, I would like to assess if there is a response. I would like to go, else we will switch to ODs as compared if there is no response.
Right. So there are 2, 3 points here. One is, in the country, if you are processing the cells in your own lab, then it is all right, but you cannot send the cells outside of your own lab according to the law. Then it has to come in the realms of clinical trials. So if you are processing in your own center, you can try it, but explain it to the patients clearly that it is still in the experimental phase and we are not sure of the benefits. There have been few studies that have shown significant improvement of PRP and stem cells, and most people would do a transvaginal approach if the ovary is clearly visible on TVS, but would prefer the laparoscopic route if the ovaries are smaller and not accessible so easily on TVS. Our experience also has not been very much to allocate about. However, the few results that we have seen post PRP and stem cell has been in the younger population. And so whether they would have anyways gotten pregnant without these interventions is something that needs to be debated. Right.
Ma'am,
So we will.
One more thing I wanted to add was, suppose if we are doing transvaginal PRPs for patients for ovarian PRPs, we thought like better to stimulate the patient little bit so that the ovary is slightly bigger and it doesn't move away when we puncture with the needle.
Very, very interesting thought and idea. Yeah, that is an it becomes clearly visible, and then you can put it on the various, at least you have to use 1.5 ml of PRP,
Yes,
1.5 ml of stem cell, and you need some area to put it in. And yeah, so I've not read of this happening, but I think, yeah, it's an idea worth discussing, at a later fora. So that's excellent. So now this is one of my favorite questions, and by this time, I think most of us are quite clear on what to do. But let me ask Dr. Saroja this question. And this is a 30-year-old. She's had 3 failed IVF, and she's come to you with the MRI report of a large fibroid, intramural, say about 6 centimeter. The MRI film that I'll show you is bigger, but say it's about 6 centimeter, but the cavity is not getting indented. Would you consider myomectomy, and why?
Ma'am, like if it is less than less than 5 centimeter, I wouldn't consider 5 myomectomy. But like the range is like 6 to 7 centimeter, and she has failed 3 IVF cycles. So I think we would go for myomectomy in this patient.
So Dr. Saroja says anything less than 5 intramural
I mean,
with
if
3
it is
failed,
not cavity distorting.
non-cavity distorting, but more than 5, we will remove.
Shall I?
Right. So,
So if it
yes,
is
please.
cavity distorting, even smaller ones we tend to remove. But if it is not cavity distorting, until less than 5 centimeter, we leave it. More than 5 centimeter, like 6 to 7 centimeter, we'll do myomectomy.
Yeah, these are non-cavity distorting. That is very clear that they are not distorting the cavity. Yes, somebody wanted to add in something?
Yes, madam. Dr. Shweta.
But
Even if the fibroid is less than 5 centimeter, but it is of like the slide also which you're showing, if it is FIGO 0, 1 or 2, then we have to definitely go ahead with myomectomy either through abdominal route laparoscopically or
No, Shweta, these
yeah.
are cavity distorting. We are
Yeah, they have to
talking
About
of 3, 4.
Intramural. We're talking about intramural, whether to operate or not. Actually, the guideline says that in cases of previous IVF failure, one has to operate for a fibroid. But honestly, in my practice, what we feel is if it is not at all cavity distorting, we are not going to go for myomectomy for such fibroids. I don't know about the opinion of the other panelist.
But if the patient is having a history of recurrent IVF failure, then we can take an option of doing myomectomy, because the size is also 6 centimeter. If anyway the patient will conceive, it will go for abortion or premature delivery and all. So we should take an option of that.
The case which
All right, let's come to the conclusion here because we are short of time. So we are talking about 3, 4, 5, and maybe 6, but this is sub-serous. And it is, see, this is a woman that you've done a TVS. There's this fibroid glaring into your eyes. She's had 3 failed IVF, and it's not distorting the cavity, but then the consensus and the literature is clear. And please convey it to your colleagues as well. You have to remove these fibroids. And even if it is I think, Saroja, you were right. It started with 5 centimeter, but now it has moved on to 3 centimeter and above. This is a study which was in women's health, biomedical research, human reproduction, meta-analysis of the effect of intramural fibroids without uterine cavity, and you need to remove them, especially with repeated IVF failures. Right. So now, Richa, this is a very simple question. I would like you to highlight there's a patient with endometriosis. She's had laparoscopy, and she's having fertility issues. You have decided to go for IVF. What are the things you will keep in your mind when you do IVF for a patient with endometriosis, right from the protocol and the preparation during egg pickup, etc.?
Okay, so since it's a case of endometriosis, first of all, I would like to down-regulate the patient by giving her a dose of leupride so that her effects are minimal. And then when she has her next cycle, and we are going to start with the protocol. Protocol choice could be an antagonist protocol, and also depends upon the individual specialist choice. But I preferably do PPOS in such patients as well, and I have seen good results. Now, coming to what is important is during the pickup and the procedure, first of all, sanitization of the canal should be with betadine so that the infection has to be taken care of. We have to make sure that she has received antibiotic prophylaxis before the start of the procedure. Third, while doing our pickups, we have to be very sure that we are not puncturing the endometriomas, and we try to avoid such punctures, and we try to keep the punctures minimum, and a good antibiotic prophylaxis post-opio.
Right. Dr. Anju, are you still here? I think she's not here. So, you're here, right?
She left, madam. She left.
Okay. So let me ask Dr. Pratibha of, Shweta, that was wonderful. I think you highlighted this betadine, and this is a very simple step which all of us must do for endometriosis. And once we clean with betadine, don't forget to have a thorough wash with saline, because we don't want that needle to go with the betadine into the follicles. So that is very important. And I'm a little, thoughtful about your protocol of down regulating and then going to PPOS. So, Meeta, you want to say anything, and what is the protocol that you follow?
Mostly in these patients, ma'am, I use ANTAC protocol, and if required, someone might use long agonist protocol also. Sometimes we can do a single dose of leupride, and then in next cycle we can just go and stimulate with the ovaries. Most of the times I use ANTAC protocol only.
So, when do you down regulate?
No,
You don't
if
down
I
regulate.
use ANTAC protocol, no. I just give an estrogen priming, and then I start with the antagonist protocol.
And when do you transfer? Do you transfer in a down regulated protocol?
Yes. Once the embryos are freezed in the later cycle, I down regulate first, and then give an HRT for FET, and then transfer.
Okay, so the studies are very clear that down-regulated cycles in endometriosis fare better. And yes, they may come on day 1, day 2, and you may have given, you can do your stimulation, you can collect your embryos, but your transfer has to be in a down-regulated cycle for more optimal outcomes. So down-regulation, you can either do the continuous down-regulation from day 21, where it is the agonist protocol basically, but the suggested protocol is at least long down regulation for 2 to 3 months prior for the best results in endometriosis. Now we will wind up with a quick case, this one and the next one, but here this is male infertility, and I want to ask Dr. Pratibha that this is a patient with OATS and you are deciding to go for IVF with ICSI for this patient. What are the factors you will keep in mind to optimize the success rate for this patient?
Since this patient is of oligoacidoteratogenesis, the chances of patient, if patient is planned for IUI, then we cannot able to select the good quality of the sperm, but
yes,
directly. In cases of oats, we counsel the patient to go for either DNA fragmentation index to see that whether its DFI is normal or not. If it is normal, then we'll give the patient option for to go for IUI. Otherwise, we'll take counsel the patient for IVF and ICSI. And in patient with ICSI also, the results, sometimes results are good, sometimes the results are not good in cases of the oats also. So and then we'll counsel the patient and we'll give option for TISA also, because in the TISA also the chances of good quality sperm is better than that of the directly from the semen.
So Saroja, how will you optimize this? You've decided to go for ICSI. It's severe oats. You cannot do IUI. DFI, I know, is a plus minus in today's world, but it has its various roles and implications. So what would you do to optimize is my question again.
So first again start with the counseling and the lifestyle factors again here. Like with the female factor, so we can counsel them like again optimal weight. If there are many medical disorders like diabetes or hypertension or any immunological disorders, to control them and have a good thing. And then again diet, exercise, and stop smoking, drinking if there anything. And specifically nowadays, if anybody is going to the gym, I'll ask whether they're taking any testosterones or anything, and optimize that aspect. Then after that, we'll do a clinical examination to see if there is if the testis is palpable or not, if the vas is palpable or not, and get an ultrasound examination. Sometimes there might be underlying testicular pathologies too, and do a hormonal profile, FSH, LH, and see how the testosterone levels are. If the testosterone levels are low, I think these patients would be beneficial by taking treatment like clomiphene citrate or letrose with HCG injections. They would be beneficial, and nutraceuticals in some patients will be helpful. We are not sure, but because the harm is less, we tend to give it. And in the scan, or if there is any palpable varicocele, or if the patient is symptomatic with the varicocele, we'll refer them to andrologist to get a varicocele repair. And if the counts are too less, if it is less than 5 million, we do the testing for karyotyping and Y chromosome microdeletions to see if there is any problem. Then we counsel them regarding what is the best prognosis. And we say like, okay, there are other techniques in addition to ICSI, like PIXI, MAX, that can help with the better selection of the sperm in these patients.
Fantastic. I think, Saroja, you have covered most of the things. And the importance of this case was that as infertility specialists, we are seeing both female and male. And it is very, very important to optimize both to get the best outcome. Smoking, lifestyle, adjuvants, varicocele repair for grade 3, grade 4, infection screening, short ejaculatory abstinence, testicular sperm wherever needed, genetic testing, all the arginine, CoQ10, all these things which may help. CoQ10 is coming up in a big way, L-carnitine is coming up in a big way, and very important to measure the testosterone, estradiol in severe oats, and if there are less, then the role of aromatase inhibitor, the role of HCG, the role of FSH to further optimize the sperms to give the best outcome is what we needed, and wherever it is required to do the PGTA or PGTM as required. So that was an excellent, description, Saroja. And this is the one of the last questions to Richa and to all my panelists. And I think this is somewhere in our OPDs, we in the rush or, we forget to ask few questions to the male partner. So what precautions would you follow and consents to ensure that there is no problem on the day of sperm collection?
So whenever I'm taking a patient, such kind of a patient who has a history of oats, and during the stimulation process, I've done a baseline semen analysis. So for the collection on the day of pickup, I would first ensure that patient did not have any ejaculatory dysfunctions prior. We would counsel 3 days of abstinence to the patient. We will rule out any other associated UTIs or any infections present in the or any complaints with the patient, and we will prefer the collection of the sample within the premises and will not prefer home collection. And in cases where they have an ejaculatory disorder or they have difficulties in giving the sample, we will try to freeze it prior to avoid any end time cancellations. And many a times when the fragmentation levels are high, or maybe we are not getting to, so in that cases, sometimes we also repeat the ejaculation. Maybe it is always seen that the second sample which has been given has a better sperm quality and a lesser fragmentation. So this is how we move forward. And if and I would like to add on one point here, that just previously discussed, that we were discussing that whenever DFIs are high, the testicular sample is required, but the recommendation says that initial 1 or 2 cycles of IVF, if possible, can be done through ejaculated sample should be preferred, and we restrict TISA or TESE only to people who have failed previous 1 or 2 cycles with the ejaculated sample. So this is, and consents, of course, we will all take it prior before. That also has been already done on day 2. So this is all we follow. Anything to add on, anybody can take care.
No, fantastic. I think two important points. Please ask the partner whether giving the sample at the center is a problem or not, because some men do have that problem. So you may freeze the sperm earlier. They can get a home sample, but whenever you get a home sample within 45 minutes to 1 hour, and a signed consent that the both from the husband and the wife, that it is their sample and they agree, this is what they've agreed to give it to us for later on any litigation to the center or anything. And a short ejaculate. So severe oats, you give the first sample, the sperm motility is not good, the embryologist is not happy. After half an hour, take another sample if possible, and you will see that has better motility and better results. So I think we will stop at this because we could go on and on and on. But thank you, Anu, for giving us extra time. And I think it was very, very interesting and enjoyable with my panelists. Thank you, my panelists.
Thank you so much.
Thank you, ma'am. Thank
Thank
you.
you so much.
Thank you,
Thank you.
Kaveri,
We
ma'am.
also
for that
enjoyed.
wonderful panel.
Thank you, Dr. Fessy. Always nice
Thank you,
to
Dr.
be in your
Kaveri, and
panels.
all
Yeah.
panelists. Very
Thank you
interactive.
so much.
Very nice.
Thank you.
Thank you. Thank you once again.
So I
Thank you once
think,
again, everyone.
okay. Nakul,
Thank
you
you,
can
doctor.
conclude.
Thank you very much. Yeah. Shall I share a thank you note?
Yes, yes.
Yes, yes.
Thank you, Dr. Fessy and Dr. Anu. First of all, thank you for being here tonight for the 7th series of our ISAR UNS Fertility Catalyst webinar. Absolutely, your presence made the event truly special. Today, we have attracted participation of 443 doctors from across the India. And I would like to thanks to our distinguished speaker. Special thank goes to Kedar sir for valuable contribution. He has discussed about the optimizing gonadotropins in IVI. Definitely, Dr. Sachin nicely elaborated about the role of letrozole in infertility. And special thanks to Dr. Kaveri for sharing her immense knowledge and insights on effective strategies to enhance the IVF success. Thank you, doctor. Also, I would like to I'm grateful to thanks Dr. Amit Patki, Dr. Bakshi, Dr. Anu, and Dr. Fessy. I must thanks. And today's chief guest, Dr. Reshma, and Dr. Guest of honor, our Dr. Parag. So thanks, and your support is invaluable to our mission. And definitely, we look forward you in our next webinar.
Thanks,
Thank you.
Kaveri ma'am, for joining.
Okay. Thank you.
Thank you, Dr. Kaveri. Thank you,
Thank you,
Dr. Anu.
Dr.
Thank you,
Fessy,
Dr.
Dr.
Thank you all
Anu.
the panelists.
Okay, good night.
And thank you, UNS, for organizing this. And thank you,
Thank you, ma'am.
ISAR.
Thank you very
Okay,
much.
okay, bye, bye.
Thank you. Good night.
Good night.
Thank you guys, भाई. बोल ना. नंद किशोर ये अपने RX-7 के क्या बोल रहे थे?
कुछ नहीं बोल रहा.
अंडरस्टूड.
मजा आ गया.
नंद किशोर भाई, थैंक यू.
ओके सर.
चलो थैंक यू यार. रिकॉर्डिंग भेज देना कल सुबह.
यस सर. लिंक भेज
हाँ?
देना.
चलेगा, ठीक है. थैंक यू.